Good morning, everybody. Welcome to day two of the Cozy Pharma event. We'll get started in just a minute. I know it takes some time for everybody to make their way in. Good morning, Dr. Onifrey. How are you today?
Greetings, thank you.
Happy Sunday. Where are you joining us from this morning?
I'm in Albuquerque, New Mexico.
Okay, so it's early for you. So this is an early morning.
Well, actually, you're earlier than I am. Are you located in California?
No, I'm in Connecticut, so I'm on the East Coast.
Oh,
So
I see.
it's
Yes,
close to
it is.
lunchtime for me.
Yeah, it's earlier for you. For me,
Yeah.
I'm sorry.
Actually, could you go back one slide for me?
Yes, I can.
Thank you. All right. Well, I will keep letting everybody make their way in, but I know that we have a lot of great information to get through. Yesterday, if you were here with us yesterday for our first day, it was a huge success. Some unbelievable presentations, great engagement from the WooU community as always. And if you're just joining us today, you're in for a treat. We have 4 hours of wonderful CE here on our day two of the Cozy Pharma weekend. So first up is systemic medications for special populations with Dr. Bruce Onifrey. And I'm your host, Dr. Jennifer Stewart. And just some reminders for each hour of CE, attendees must be online for a minimum of 50 minutes. This is a 2-hour course, so you do have to be here for 1 hour and 40 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARVO with your OE tracker numbers. There'll also be a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. And throughout the presentation, make sure to ask questions using the Zoom on-screen floating panels. You can use chat and Q&A. Since this is 2 hours, don't wait till the end to put your question in there so you don't forget. Feel free to add those questions throughout the presentation as you have them. We're going to leave about 10 minutes at the end for Q&A. If you're on a mobile device, you can also find Q&A in chat. So it's my great pleasure to introduce Dr. Bruce Onifrey. He is a 1982 graduate of the Illinois College of Optometry and residency at the Albuquerque Veterans Administration Medical Center. He also has degrees in chemistry and pharmacy. He retired from the Lovelace Medical Center eye department after 25 years, where he served as the chief of optometry and vice chairman of eye services. Most recently, he retired from the University of Houston, where he served for 10 years as a clinical professor responsible for pharmacology programs, attending physician on the Ocular Disease Service, and the executive director of continuing education programs, and primary care residency director. Currently, he works part-time with the Kiwa Pueblo Community Hospital in Santa Fe, New Mexico. His special interests include lectures in general and ocular pharmacology and clinical drug research. He's a frequent contributor to ophthalmic literature, the current editor of Clinical Optometric Pharmacology and Therapeutics, and the author of the oh my gosh, I need a cup of coffee. The Ocular Therapeutics Handbook, a clinical manual, which just released its 4th edition. He's an internationally recognized lecturer on the management of ocular disease and the use of pharmaceutical agents. Good morning, and I am excited to have you here. I'm going to turn it over to you, and I'll be back for the Q&A.
Greetings, folks. I've made sure to put my email address here. If you have any questions, don't be afraid to send them. This course is associated with a test, 10-question test at the end. If there's any questions on issues you have with that test or understanding the questions or finding the information in the handout, please don't be afraid to contact me for any questions or updated handouts or anything else you may require related to this lecture. So it's idoc3@aol.com. The important word here you see in this title is case-based. It's important to note that I've tried to make this as practical as I possibly can. I taught a lot of this stuff in school, and there's a certain format for school for students versus active practitioners, and so I'm trying to make this as relevant as possible to your practice style. So who is special? You are. And that sounds funny at first, but what it really is intended to mean is that you have to make decisions on very vulnerable patients. So you have to decide what medications a person takes. And when you give a prescription to a patient, they assume that you know what you're doing and that you're not going to hurt them. Again, the first rule of medicine is first do no harm. So you do have to make these decisions. Certainly, it's not in a vacuum. You have resources. You shouldn't be afraid to call other specialists, particularly when it relates to pediatricians and OB/GYN docs. But again, you at the end of the day are making the decision, deciding what is safe and effective for that particular patient. So this is important. Most importantly, with systemics, we don't treat everybody the same. That's why this is called special populations. It's based in large measure broadly on age, weight, and body surface area, which we'll talk about later. You see patients like this, very different weights, ages, et cetera, all the characteristics that we'll cover through this lecture that make a person unique has to be taken into account when you decide what they're going to take and how much you're going to give them. So to be more specific, a special population includes pregnant patients. This is basically a lecture on peds to pregnancy. Reduced renal function is incredibly important, particularly in our high diabetic population. Tons of, when I practiced Kiwa Pueblo, a good 75% of the patients are diabetics. Patients take other drugs that can interact with the medications you prescribe. Of course, their age is a factor. We'll talk about that. Reduced hepatic liver function based on age, drugs that they take, and diseases that they may possess. And of course, the broad sense of pediatric population is special in itself. To me, that's anyone under the age of 17. Why do they decide that age for that particular population? Because that's the age when the liver becomes mature and can metabolize drugs as an adult. Anything younger than that, we have to take into account that the body handles the drug differently. Absorption, distribution, metabolism, and excretion are all important to understand as being different in the management of prescribing in this population group. This is an old slide. Know your drug class for the pregnant patient. This does not exist anymore, but it was pretty straightforward. A was a drug in that class was absolutely safe in pregnancy. That was water and maybe a few other things. Not too many drugs had an A classification. B was probably safe. C, this is where we got into a bit of difficulty and to decide risk-benefit ratio. When we gave a drug that was a class C to a pregnant patient, it really had to benefit the patient more than the risk. D was, in our sense, as an optometrist, I would never prescribe that drug unless the condition was life and sight threatening. And X means absolutely never give this to a patient who is pregnant because it has a 100% chance of producing fetal abnormalities. So the old X drugs that are classical, for example, is doxycycline. I'll be talking about that today because I had to limit the scope of this lecture because of the time and also the fact that most of the drugs that we prescribe to particularly pediatric populations are for infections. And so we're going to basically talk about anti-infective medications in the group of drugs we cover today. Another one is Accutane, which is an acne medication, which is also notorious for producing fetal abnormalities. So these drugs were never okay, and particularly the doxycycline. And some other ones I'll talk about also would be considered X drugs for the pregnant population. But we don't use that anymore. You have to do a little more thinking. This is how it's changed. The new pregnancy safety rating system is in the package insert, or you can look in resources like facts and comparisons. I'll talk about that a little more in a second. But basically, it's under the category of pregnancy and lactation. And as you can see, pregnancy includes labor and delivery. Pregnancy exposure registry is listed in there, talking about what's happened to people who have been pregnant that have been exposed to the drug, what their outcomes were, their risk summary, clinical considerations, i.e. risk versus benefit is at the bottom, at the soul of this whole thing, and ongoing data. So this is an evolving type of process. It's not just giving a drug an X or an A or whatever. The data is updated as it comes in. What we have to do again is make a decision based on this data. And don't be afraid to discuss with the appropriate medical specialist, whether it's a pediatrician or someone else. So again, the burden is on you to evaluate the data. We are scientists at the heart of our profession, and so we should be able to do this. So reduced renal function is an important factor. Again, the way the drug is metabolized and excreted is critical and the kidney is critical to this process. Creatinine clearance is the magic word for this, and it can be calculated with the Cockcroft-Gault equation. I just put it in here just for your information. I want to be complete in this discussion. Ideal body weight in kilograms times 140 minus the patient's age. So importantly, you can see that age is inversely proportional to creatinine clearance in the calculation because it's in the numerator, and it is subtracted from the number 140. 72, which is also a constant like 140, is multiplied times the serum creatinine. So basically, the patient has to know what their serum creatinine level is, or it has to be measured to do this formula. And that is multiplied. That answer is the correct answer for males. With females, it has to be reduced by 15% because of the general understanding that their muscle mass is less than the male. So there's this automatic deduction for females. So drug risks include that affect the kidneys. The main one that I think of is NSAIDs. NSAIDs reduce blood flow. Anything that blocks prostaglandins blocks the good and the bad prostaglandins. And prostaglandins are responsible for increasing blood flow to the kidney. It's important to know that, and reduces again renal function, and it means that the creatinine clearance will go down with the use of NSAIDs. And if they're used long enough, it can damage the kidneys. The other big deal that we talked about earlier is diabetics. All diabetics will have some degree of renal compromise. We don't know what that is. Now, fortunately, when I practice in my medical record, electronic medical record at the Pueblo Hospital, I have all the results of all laboratory tests that patients who belong to that clinic. And again, these are indigenous patients, Native Americans. And so I have that whole population that's coming in for care, all their data, all their lab tests available to me, so I can make these decisions fairly easily. I can also communicate easily through that system, or I can pick up a phone and talk to one of the other providers to discuss my care with the patient or my findings of the patient. But it is important not to operate in a vacuum. If you ask yourself, where can I get this information? Again, you can get it from the patient's doctor if it's important to you to know that. And again, it's important to have a discussion with that other provider in terms of what your intention is to treat that patient if they're at risk. Reduced hepatic function, the liver is critical to detoxifying and altering a drug, metabolizing a drug essentially. There's two processes, the phase one oxidation that occurs, and then if there's further metabolites that have to be changed, they can be conjugated with another organic compound, to everything is directed in the body at increasing the polarity of whatever they're trying to excrete. It allows the kidney to grab onto it and actually excrete it. So conjugation will increase polarity of an entity of a particular drug to make it easier to excrete. The liver does not detoxify. It can actually make things more toxic. For example, if you're metabolizing acetaminophen, Tylenol, 5% of the metabolites of Tylenol are toxic, but in a healthy liver, that toxic compound is conjugated into a non-toxic form and excreted. If we have a compromised liver, that doesn't occur, and these toxic compounds can accumulate and increase hepatotoxicity. It's important to understand that the number one cause of acute liver failure in kids is taking Tylenol, an excessive dose of Tylenol. So it is a dangerous drug. It should be under consideration if a person drinks too much, if they have had a liver transplant, if they have hepatitis, and of course, if they have diabetes as well, because their kidneys aren't functioning 100%. So under the age of 16 years, the liver has not become completely mature. Alcohol consumption greater than 3 drinks a day is an absolute no-no to using a drug like acetaminophen. As I mentioned, hepatitis, first pass effect is important to note. That means that when the drug first goes to the liver before it goes to the rest of the body, a lot of the active drug is metabolized. So that's how we have to adjust our dose. And if not a lot of the drug is taken out because of the fact that the liver isn't working very well, then we have to reduce the dose in that particular patient if they have reduced liver function and the drug is metabolized by the liver. Some drugs are not. Abnormal bleeding history is the first sign, believe it or not, because the liver makes vitamin K dependent clotting factors. So believe it or not, if you see a patient bleeding abnormally, one of the considerations in the tests that we order are liver function tests. So special dosing formulas, I'm going to throw a few of these out there for historical sake. They're based on age, weight, and body surface area. Young's rule is obsolete. You don't need to know it. It's just, again, historically important. All these calculations were designed to come up with a lower, supposedly safer dose for the pediatric patient. And it's based on their age in years divided by their age plus 12. Where they got these numbers, I have no idea. And that's why we don't use this anymore. But at the end of the day, we have this example of a 6-year-old. We take the formula, the age 6 on the numerator and the denominator 6 plus 12. We figure that out and we come up with a lower dose. And based on Young's rule, this would be the alteration of the adult's dose to give to a 6-year-old. Well, that didn't work so well, so they came up, again, I don't know, they might have figured this out on a cocktail napkin at cocktail hour. I don't know. But Webster's rule was called a modified Young's rule because the doses were coming out too low and kids were getting fatter. So they came up with age plus 1 year divided by age plus 7 again. The whole thing was designed to reduce the dose from adult. And in this case, we come up with about a 30% higher dose of acetaminophen for the kid. Again, obsolete rule. We don't use it ever. Clark's rule is different. It's important. It's based on anyone who weighs less than 100 pounds, essentially. And we can use this to calculate a dose for anyone under 100 pounds to modify that dose downward. So it's based on weight. It's realistic. It is individualized. The one problem with this formula is obesity. If you have a 13-year-old that comes in who's a future NFL lineman, football player, and weighs 250 pounds, this thing is not correct. When you look at the facts and comparisons of other resources, you will always see a maximum pediatric dose. Do not exceed that dose, even if the kid is really heavy. So this is more of a guideline, not the actual calculation. But you can do it in pounds or you can do it in the metric system. You take the weight in pounds divided by what is called ideal male body weight, 150 pounds, and that fraction should produce the pediatric dose. And what I've done here is taken 3 6-year-olds and I've tried to individualize them by the fact that they have different body weights. We're not, just because they're the same age doesn't mean they're the same. And again, with acetaminophen, I've taken the standard adult dose, which is given every 4 hours of 650 milligrams. Remember, extra strength Tylenol, 1,000 milligrams for acetaminophen is not a standard adult dose. That exceeds most recommendations. Anyway, taking the formula, dividing 50, 60, or 70 by 150, we have reduced dosages that are individualized at 216, 260, and 303 milligrams. Or you could do this in kilograms if you want to. Make sure you do that calculation properly. We'll talk about that. But the ideal body weight of a male in kilograms is 70 kilogram denominator. We do use this. I use this as a guideline. I try to double check my calculations, and I'll show you the different ways we calculate that. This is a secondary calculation. It's not the primary one we use, but it's a good rule of thumb that we use as long as the child is not obese. This is you'll see this in certain references. This is body surface area. It is the most precise way to measure a dose. It's used very commonly in newborns and infants. The example that I've used here is both in metric and non-metric. We take a 3-foot 3-inch tall child weighing 44 pounds with a body surface area is calculated by taking that height and weight, dividing it by a constant, 3131. Now, this is where people make a mistake. You get an answer. Now you have to take the square root of that answer to come up with the child's actual body surface area. From there, it's very much like Clark's rule. You're doing a fraction where the kid's body surface area should be less than the standard adult, which is 1.73 square meters, and you divide the child's body surface area by the adult's. Multiply that fraction, which is should be less than 1, times the dose of the adult, and you'll come up with the modified dose. This is, as a pharmacist in the hospital, this is what I used to use in calculating IV dosages for children. It's that specific and important. But again, using oral medications that we use, this is not critical, and it's not the thing that we normally run into or that I use. But I do want you to be aware that it's out there and how to do the calculation. One other point, you can see that I have the two formulas, both in metric and non-metric. When I did my calculations, I would always do it both ways because the answer should come out to be the same. That would be the way I would double check myself. Quick note again, these formulas should always produce a lower dose than the adult dose. The purpose is to calculate a reduced dose. Remember, if it's higher than the adult dose, you did something wrong, okay? I have the old saying, don't follow your GPS in the lake. Well, a person drives into a lake, the policeman says, why did you do that? Well, my GPS said to turn left, and there I did. Again, keep your eyes open, watch the context of everything, make sure that the dosing is logical, double check yourself, and again, triple check yourself on these situations of drug selection and dosage. This is what we use 99.9% of the time as a primary calculation to determine whether or not what the drug's dose should actually be. The weight that they use in the references is almost always in kilograms, so be familiar with metric. I know it's un-American to know the metric system, but please learn it. That's what we need to do. When they give a dose that you calculate, it's for full 24 hours. So this is where nurses and other providers get in trouble when they give the drug. They forget to divide by the frequency of dosing. If the dose is for 24 hours and you're giving a TID, each dose is 1/3 of your calculated dose. Don't make that mistake. You have to know the concentration of all liquid forms, the amount of drug in milligrams usually per volume, per cc. And you have to know the strengths of all solid dosage forms so you can deliver the proper dose and dosage form based on your calculations. Here's an example. This was a case interesting. I had a 3-year-old present to my clinic with a rash across his face, including his eyes, swollen eyelids, etc. And he was taking a teaspoonful of an antihistamine Benadryl, diphenhydramine TID. And that is the maximum allowed dose for that child's age and weight. And it wasn't working. So I called up the pediatrician and I told him what was going on. He said, well, give him a steroid, and he hung up essentially. So here we are. Fortunately, I know what the proper dose of steroids are. Now, prednisone has a dosage range, you'll see at the bottom in my note, of 0.5 milligram all the way up to 30 milligrams per kilogram per day. So what do we use? Well, here's what I use for optometric patients. And this is for all age groups, infants all the way up to the elderly. 1 milligrams per kilogram per day is a 24-hour dose for mild to moderately severe inflammatory reactions. So this kid has been exposed probably to something like poison ivy. So what we did was we did a calculation for him to take a pediatric preparation that we'll talk about. It's also important to note that I gave him prednisolone. Well, there are steroid equivalents depending on cortisol or prednisone or which steroid you use. And it's nice to know that prednisone, 5 milligrams, the equivalent in methylpred is 4 milligrams. We're essentially identical. So if you're prescribing methylprednisolone, use the same formula as you would for prednisone. So in this case, Pediapred syrup contained 5 milligrams per 5 mLs of prednisolone as the active ingredient. So now we have to do a calculation. I don't know if any of you have ever gone to Mount Rushmore. I have. It's pretty awesome. But a lot of people, when they go there, don't take time to walk around the other side of the mountain. Sometimes the whole truth requires looking beyond the obvious. So if you go behind, it's even more fascinating. It's just incredible. So let's get the whole picture. Look at all sides of the problem. So let's break this thing down. Our pediatric dosage calculation starts with us changing this kid's weight to kilos. Remember, kilos are always less than pounds because we're dividing by 2.2. So this kid's 33 pounds turns into 15 kilos. Next step, we know that's a 1 milligram per kilogram. Simple. 1 milligram times 15 is equal 15 milligrams per 24 hours. Now, the interesting thing with steroids is you can give them once a day, all the way up to even in divided dose 4 times a day. I think I don't want to go to 4 times a day, but I do want to give it with meals, and it's more convenient to give it 3 times a day. So that's what we did. We divide 15 by 3, so it's 5 milligrams per dose. Now I have to know the concentration, how much drug per cc to give this kid so I can get the proper dose. So we know that there's 5 milligrams per 5 mLs. Why do they use 5 ml liquids? Because that's a teaspoon. It was convenient, but drugs are too potent now. We don't use teaspoons. We use metric mLs, and we measure precisely. So we divide 5 milligrams by 5 mLs, we get 1 milligram concentration for every cc or ml that we deliver. We want to give 5 milligrams of drug 3 times a day, so it's 5 mLs TID by mouth, and that's how we would write that prescription. And we have to remember that we're giving that 5 mLs because it contains our calculated dose of 5 milligrams. It's important to understand the concentration calculations here. Now, I normally take questions, but again, you can give your questions to the host, and I'll be glad to address those at the end of the lecture. Facts and comparisons is commonly, it's in my electronic medical record embedded in your pharmaceutical part where you actually prescribe. You can usually find under references. Very important if you have any issues about understanding the updated guidelines of the drug, particularly in pregnancy, you can find it in there. And it's always updated on your database. So if you don't, otherwise I would go online and you can check the package insert that way by looking up the drug. GoodRx is another source you could also use. Patient eye doctor, why do you want to know about my liver, my kidneys, my heart, my credit report? It's because individuals are different. This person sits in your chair and says, Dr. Onofre, I can't see very well. Then I walk over to room number 2, and she says, Dr. Onofre, I can't see very well. Well, what's the chance of them having the same reason for not seeing very well for their chief complaint? The kid on the left could be keratoconus, they could be amblyopic, or just common to both refractive error. Whereas the patient on the right, macular degeneration, advanced glaucoma, cataract, etc., corneal disease, whatever. So the fact is that these people are different. Their differentials are different. Their treatment is different. Histories are important. Medical, eye, allergy, medications, family, their social history. Do they smoke weed? Whatever. Are they smoker in general? Their demographics. I have an Indian population much more prone to diabetes than any other population. They get chlamydia at a much higher rate than other populations. So again, I treat them differently because my expectations of what's wrong with them is different. Just as an example, yeah, you can have this as reference, but it just is shown to how important it is, the difference the way the body handles the drug based simply on age. The plasma half-life in a young patient, old patient, of all these drugs is extremely different based simply on the patient's age because they metabolize and excrete at a much different rate. That's why it's important to make these modified dosages. Another one is we all come in with looking on the left with their fundus photo where we see drusen and macular degeneration. And what's the first thing we tell them to do? Well, stop smoking and change your diet to green leafy vegetables. All right. Well, if they do, that would be a profound error if the patient is on Coumadin because green leafy vegetables contain vitamin K. If you suddenly change their diet and you give them more vitamin K than they're supposed to, the Coumadin dose would be too low and they're going to have a heart attack or a stroke. So that's why we have to know what's going on with this patient before we even make simple dietary changes in these patients. So no spinach for patients taking Coumadin, okay? No green leafy vegetables. Do not change their diet. Another factor that we see, particularly in the elderly, are cardiopulmonary disease. It's the #1 cause of death in the United States. So anyone over the age of 50 is going to have some cardiac compromise to some degree. It may be mild and undetectable, or they may actually be treated for it. If they're taking vasodilators or blood pressure medications, it's really important, or calcium channel blockers, These people are very sensitive to other medications, so make sure that you take that history and be aware of that before you give other drugs, particularly autonomic nervous system medications that can affect the other drugs doing their job. So most common condition in elderly patients take multiple meds. The average number these days seems to be 5 to 10 drugs for anyone over the age of 60. Dosages have to be carefully titrated. So if you're altering the metabolism excretion of their other drugs, you're going to put them in trouble either for underdosing or overdosing now. And again, the very fine line between the risk and benefit with meds. Know your drug interactions. These are drug-drug, that is between two drugs, or the drug and the patient's pre-existing conditions are things we have to know. Conclusions. Children are not little adults because it's not just the fact that they're smaller based on weight, but also their metabolism is different. The way they handle drugs, dosages have to be based on actual pharmacokinetic factors, absorption, distribution, metabolism, and excretion. Pediatric dosage formulas can only estimate a proper dose. We have to try to be as specific as we can with that given child, looking at their total histories. Peds are always at greater risk for drug-induced toxicity, so go low and go slow, except, let me give you a warning to that, don't underdose antibiotics. I'll mention a word here, high therapeutic index. That means a safe drug. Drugs like penicillin, if they're not allergic to it and have a high therapeutic index, where because of resistance of antibiotics these days, with those types of drugs, we tend to go at the higher end of the dosing range. And I'll talk about that in examples. Any doubts, talk to the pediatrician or the appropriate specialist. Again, I'd normally take questions now, but we'll move forward because I have a lot to cover. This is a very good reference. You can get this online, both of these books, Pediatric Dosage Handbook, etc. Again, always kept, again, if you have any doubts, call the pediatrician. Now, I had an interesting thing occur when I was testifying in legislators for drug privileges and drug laws for optometrists. I had a PharmD, a doctorate in pharmacy, testify before me to the legislator. He said that ophthalmologists and optometrists don't even need to use oral medications because we're treating the eye. We use drops are fine enough, so we don't have to do that. I knew that was a ridiculous statement, but I had to have a response to that. So here's my response to why do optometrists need to use systemic medications? These are the top 3 reasons. I just love saying take this medication stat because it makes me feel like a real doctor. 2, it keeps people from trying to swallow their drop. I hate when that happens. Number 3, patients, some of them need a suppository. In fact, they benefit from a really large suppository. Kind of funny, I hope, but at the end of the day, this is significant because making a stupid statement like that optometrists or ophthalmologists don't need systemic medications is ridiculous. It's clearly a sign of ignorance on that person's part of not even knowing what we treat and what it takes to treat. But it is important for me, talking to you, to explain exactly why we need these and how we use them, their proper indications and their dose, et cetera, along with the dosage and safety profiles. So we have to use systemics when topicals are not enough. You don't have to feel obligated to use them. Just because you have the law doesn't mean if you're uncomfortable, take your time. You have to crawl before you walk, before you run, but make sure that you're comfortable using them. And if you don't, the important thing is to note, I was in lectures and people would come up to me and say, but Dr. Onifray, our state doesn't allow us to do that. Well, I don't give a damn. That's what the patient needs. If you can't give it to them or don't want to, then you need to send it to somebody else that will, okay? Your limitations shouldn't be the treatment limitations. Keep that in mind as well. So sometimes eye drops aren't enough. You can see that this internal hordeolum, I call it bad. It's worse than a external hordeolum or a sty. This is worse, so I call this real bad. And this is baddest of all. We have adactyl cystitis. We'll talk about these in a little bit. So we have levels of infections that put the patient at risk that require different forms of therapy. So let's start with this one. Is it ever appropriate to treat acute conjunctivitis with systemic antibiotics? Well, we've got a 5-year-old. He has a history of ear infections over and over again. I've seen him in to see the doctor many times in his record. They call it pink eye for the last 4 months. Developed red eye again yesterday with discharge, low-grade fever, 101, 100 to 101 times 24 hours, and have a purulent green discharge without any preauricular nodes. So let's talk kids. Pediatric conjunctivitis plays by different rules. We have to check the history, which we did. They told us about the ear infections. They told us about the throat infections. The kid has a sore throat. I don't have to look in the throat. I can ask. And you can always check the temperature if you want to. This is the statistics. Etiology of acute conjunctivitis in kids. The number one, in adults, it's adenovirus. You can see that's 20%. But H flu, Haemophilus, is 42%. Now, they have a vaccine for that now, but it's only dropped the incidence down to 32%, which is still makes H flu conjunctivitis in pediatrics, kids under the age of 6 in this case, the number one cause of infectious conjunctivitis. Or I should say, even broader than that, acute conjunctivitis. And the bad thing about H flu is first, it's gram negative. It's important to know that. It resides in and colonizes in kids the upper respiratory tract right here. And from there, it can go through the eustachian tube into the middle ear, or through the nasolacrimal duct into the eye, or down into the pulmonary system, lower pulmonary system to the trachea, and cause pneumonia. So this is something that the kid basically colonizes. We have to manage as a systemic infection with risk of spreading. Keep that in mind. So no drops alone if there's recurrent or active otitis media, fever, sore throat, generally ill. Now, I treat topically with polytrim because it is polymyxin B. Trimethoprim is good against gram-positive and gram-negative, but I actually prefer the fluoroquinolones like moxifloxacin for this. It's TID instead of QID, and it is very effective against gram-positives and gram-negatives together. And we'd also choose an effective drug that works against H flu, which is at the heart of this lecture. And we'll talk about that in a second. Let's go forward with a few more examples. The sty that wasn't, when topicals are not enough. In this case, we see it again in good internal hordeolum, a juicy one, active. We would call this, again, internal hordeola. Another condition that presents that is not localized, important to note, the difference is erysipelas. Now, if you look at this patient, you might say, well, that's an allergy. I'll give him an antihistamine. Well, no. The first question is, does that hurt? Go ahead and touch it. It hurts. If it's infected, it hurts. The thing about strep infections is they do not localize. They spread through the subcuticular tissue, and they are very nasty. It can easily go orbital cellulitis, superficial non-localizing infection, as opposed to staph, which tends to localize into an abscess, like we saw in the first slide. Again, strep species here, erysipelas. So here we have a good example of what looks like a preseptal cellulitis. This kid is only 15 years old, big kid, and it came in to see me for this. Now I have to make a differential here. We want to make sure that it is not orbital cellulitis. And you can see here that when we, in this example, this is not my patient, pulled up the lid of the affected eye and asked him to look upward. Well, that eye is frozen in the socket. So that is not preseptal cellulitis. Proptosis, classical sign, decreased acuity, the proptosis, diplopia, extraocular muscle restriction. Patient is usually febrile. They have elevated white blood cells, septicemia, that is. So they get blood cultures, and you have to really get imaging on these patients to see where this is going and where it's at. So again, don't make the mistake of treating an orbital cellulitis as a preseptal. And secondarily to that, why do we use oral medications? To prevent it becoming an orbital cellulitis. It is life-threatening and sight-threatening. Kids have to be hospitalized. IV therapy is the treatment of choice. That's why you have to make the differential diagnosis. They're life, sight-threatening conditions. Based on culture sensitivity reports is what they actually treat it with, and make that decision IV. And one of the most common cause of this is an insect bite, as simple as a mosquito. My brother, when he was 4 years old, I remember my uncle was a physician, and at that time they actually made house calls. And he was afraid my brother was going to lose his leg. He was bitten by a mosquito, he scratched it, and it became this nasty cellulitis around his knee. And he kept coming, giving injections to him throughout the days, and eventually it improved and he didn't lose his leg. But my point is that kids scratching insect bites or other little scratches that they get in the course of being a kid can turn into a really bad situation. So my number one antibiotic of choice for the cases I presented so far is amoxicillin and clavulanate. I love these synergistic combinations. The amoxicillin is the active ingredient, and clavulanate attracts penicillinase. So if a staph or strep produces penicillinase, the clavulanate neutralizes it before it can cleave and destroy the active penicillin molecule. That's why this is so effective. So you've got a double type drug combination. It comes in many different dosage forms. The adult forms are 500, 1,000 milligram, and 875 milligram tablets. It's a BID drug, which makes it more convenient. Comes in all types of pediatric dosage forms, liquid 125 or 250 concentration per 5 cc, and it also comes in chewable tablets. Its indications, as I've shown you some examples of, are preseptal cellulitis, dacryocystitis, pediatric hemophilus. Hemophilus, remember, is gram-negative, and so amoxicillin with clavulanate is effective against gram-positives, gram-negatives. It's important to know the spectrum of activity of the antibiotic that you choose as it relates to the pathogen you're trying to treat. I hope I'm not going too fast. I am trying to get through. I have to cover a lot of slides here. So again, if there's any questions that pop up from this, at the end, we'll try to address it, or email me, please. I don't like to rush, but I do want to move at a directed pace here. So augmentin amoxicillin clavulanate is broad spectrum, so it's effective against staph, strep, and hemophilus. Staph and strep are gram positives. And again, effective even more detail than that, whether it's gram positive, gram negative, it's a penicillinase producer, which the three above pathogens are all penicillinase producers, even if they're gram positive, gram negative. That's a separate issue. And again, clavulanate blocks penicillinase. That's important to know. It has a high therapeutic index, so it's safe. You can give an almost unlimited amount of penicillin to a patient without toxicity. It's bactericidal. It doesn't put it to sleep like a bacteriostatic. It kills the organism. It has low GI side effects, which is good, and it's only given twice a day. It is absolutely safe in pregnancy unless this is a non-dose dependent risk. Allergy. You don't have to give a person a lot of drug to kill them. And that's with an allergy, an anaphylactic response. Fortunately, less than 1%. Most people have a rash. And that's a warning sign. You don't then give it because they just had a rash, because it can turn into the next dose can get worse. But usually less than 1% have a life-threatening anaphylactic response the first time around. And it's cheap because it comes generically. I am not pushing any brand name drugs here or any particular drugs in general. I don't get paid by drug companies. These are not infomercials. I'm just giving you the information directly because I want you to know the drug to use, because that's the center of this lecture, is drug selection. This is a kid who had a dacryocystitis. Now this kid, let me talk about the treatment of this kid. We gave him a topical fluoroquinolone because the dacryocystitis had spread up through the puncta into the eye and produced a topical conjunctivitis, a bacterial conjunctivitis. But it also had broken through the lacrimal sac into subcuticular tissues and produced a secondary abscess. So this kid gets warm compresses. He gets topical medication to avoid the spread of the bacteria into the globe. He also gets oral augmentin. In this case, we used 875 milligrams twice a day, a higher dose. Now you can get it in 1,000 milligrams if you need to. I also, in our state, we're allowed to use anesthetics and use sharp objects on patients. So I took a number 15 blade, a sharp-tipped scalpel, and drained the abscess. As you can see, we left it open so it could continue draining. And you can see the great response. All the cellulitis is gone. We just have some localized swelling and inflammation around the treatment area, which is still draining. And in this case, this is after only 2 days of treatment. So I'll check him again after 7 days. And if I need to, I'll re-prescribe the medication if necessary. But you want to give at least 7 days and high-end dosing range, which we'll talk about in just a second. But very effective medication for these types of infections. Augmentin dosing, see the dosage range for peds is 25 to 45 milligrams. I never use 25 anymore. Now for younger kids might go to 30, but in general, my dosage is around 40 to 45 milligrams per kilogram per day, twice a day. That's the most convenient. They tolerate it well. You can divide higher dosages for smaller kids into a TID dosing if you want, but remember that let's say that 45 milligram dosage is for the full 24 hours. So you divide it by 2 or 3 for each individual dose. For adults, I rarely use the 500, but it depends on the infection. Again, milder ones, smaller patients, I might use the 500. But remember, there's a lot of resistance. So 875 to 1,000 with 875 milligrams twice a day tablet being the sweet spot for treating adults. Just remember, you have to make sure they're not allergic. If they don't know and they've never taken penicillin, and their relatives, some of their close relatives are allergic, mother, father, sister, brother, aunt, uncle, I may default to a second line treatment. So keep that in mind too. Adult Augmentin prescription, you can see here, Augmentin, or in this case, I don't like to write out amoxicillin clavulanate. I'll just check the box at the bottom that says generic because it's easier to write Augmentin. And I'll write 875 usually tablets. Number 20, a 10-day supply is a usual that I give 7 to 10 days. One tablet Q12H, which is BID, and I'll tell the patient specifically, take this drug at 8 and 8, 8 a.m. and 8 p.m. or very close to that. I never give a refill on my antibiotics in most cases unless they need to take a 10 to 14 day supply, and some disorders require extended treatments. We'll talk about that later, but I will have them come back. I'll refill it if I feel they need it. Here's a pediatric prescription that I use for a 7-year-old that weighs 50 pounds. Augmentin, 250 milligrams per 5 cc oral suspension, a 200 cc bottle. It comes in 100 and 200. We'll talk about that in a second. The dose is 10 mLs, and in parentheses, you could put the actual amount of drug that would be. In case of a 250 per 5, that's obviously 500 milligrams. Every 12 hours by mouth, PO. Make sure you put the PO on there. And again, no refill. So how did we get to that RX? Again, let's go back to our formula. The kid weighs 50 pounds. We divide that by 2.2 and come up with 23 kilos. All right. 23 kilograms times 45, which is my magic number here because I work at the higher end of the dosing range, is equal to 1,035 milligrams per day. We're going to give it twice a day. So we divide that by 2. So the individual dose per day, BID, is 517 milligrams. We know that the drug contains 250 per 5. So that turns out to be, we divide 250 by 5, we end up with 50 milligrams per ml or cc, same thing. So to give this kid 517 milligrams or 517 milligrams per dose, we divide that by 50 and we come with an individual dose of 10 mLs twice a day. Okay, if you don't understand that, don't prescribe this stuff. All right, you have to, it's like calculus. You have to know it. At some point it'll click, and other times it's like I always felt sometimes when I first ran into calculus, it was like teaching calculus to a dog, because it's all on the basis of your basis of math, like algebra, et cetera, is so important in the calculations. You have to reach back and get your head wrapped around it. This is not difficult, but it is important. In calculus, nobody died. But in this situation, people can die and be injured by giving wrong drug, or in this case, wrong dosages. But doctor, I'm allergic to penicillin. What am I going to do now? Okay, we should know that because we ask the questions. One of your alternatives would be Zithromax or azithromycin. Again, very popular drug. It's in the top 5 of prescribed drugs every year in the United States and worldwide, actually. Certainly a big one as an anti-infective. So what's the benefits? Broad spectrum. That means it kills gram-positive, gram-negatives. It's a macrolide. Not all macrolides are broad spectrum. For example, erythromycin is only gram-positive, some gram-negative. So this is more effective than that. It has a long half-life, so that means that it lasts for a long time. So we don't have to give dosing frequently, and we don't have to get for a long period of time. A 3-day dosing regimen lasts for 10 days. So don't keep giving this more for 10 days. This is an exception to the rule. This is 1 to 3 days maximum. Mild to medium GI side effects. Macrolides like erythromycin are notorious for GI side effects. Because we're only giving it once a day for 3 days, it doesn't have a chance to cause that many side effects. So that's why it's so good. Excellent compliance for, in some cases, like for treating adult chlamydia, you only give a single dose. Very handy. Moderate cost, it is generic and should be prescribed as a generic. Drug interactions, long-acting antihistamines like Claritin or loratadine can be affected. This drug interferes with the metabolism of Claritin, for example. And when Claritin builds up in the body, isn't excreted normally, it can reach toxic cardiac levels and produce slow heart rate. So keep that in mind. What I ask many people on oral antihistamines, all I ask them to do, I don't care what antihistamine they're taking. I just say, stop the antihistamine while you're taking the drug. Okay, and for about a total of 7 to 10 days after you stop the drug. In fact, it has to be, in this case, because it lasts for 10 days, make it 2 weeks. Don't take your antihistamine for 2 weeks and, and after the start of this medication. Azithromycin indication dosage forms. Its drug of choice is a penicillin substitute. You should know that. It's effective against pediatric hemophilus. You should know that. Dosage forms include the Z-Pak, which I never use. It's obsolete, done, gone, forget it. It required a double dose on day one and then a single dose for the next 4 days. People aren't that smart. They make mistakes, so and do not do that. The tri-pack, the 500 milligram for adults, is what we use. And for kids, we can use 100 or 200 milligram per 5C concentration of suspension. So the tri-pack, which is also kind of obsolete now, some pharmacies might still carry it, but now they carry it in bulk. So you just write number of pills 3. And so that's all you don't necessarily have to write a tri-pack, just the number of pills that the patient takes. Prescribe any amount that you give the patient. It's normally 3 pills, 1 pill a day for 3 days. And I use this for, instead of doxycycline for chronic blepharitis. In this case, what I do is I give a 3-day dosing regimen, 500 milligrams a day for 3 days at the beginning of each month instead of doxycycline. It's very handy. It's about as 70% as effective as doxycycline. 100 milligrams a day is for treating chronic blepharitis or chronic blepharokeratoconjunctivitis that we see in young children. And I have to use a substitution for young children because they can't take doxycycline if they're under the age of, usually I like to use 12 as a marker for that. So I prefer to use that. But this is nice. It's like almost like a birth control pill you'd take at the beginning of the month. It would be 1 pill a day for 3 days, and the appropriate dose for that child or adult if they have chronic blepharitis. So I can do that for months to prevent a reoccurrence of their blepharitis. I'm talking about like things like acne rosacea, really inflammatory blepharitis or blepharokeratoconjunctivitis, which causes corneal scarring in children. I don't want to get into that here, but I did mention that as a substitute for long-term management of lid disease. So pediatric dosing options for azithromycin, excuse me, the 5-day regimen is a no-no. Again, it would be 10 milligrams per kilogram per day on day one. Then you have to shift gears, where the person giving the drug has to shift down to 5 milligrams per kilogram per day for the next 4 days. Forget it. Stupid. Here's the new pediatric one. 3-day treatment, 10 milligrams per kilogram per day, once a day for 3 days, done. You can go up to, in cases like chlamydia, or even 1-day dosing of 30 milligrams per day, a single dose. Don't do it. Kids will get upset stomach and even throw up the drug. So follow the 3-day regimen at 10 milligrams per kilogram per day. An alternative that nobody uses anymore, but I'll mention, is Biaxin, a twice-a-day drug. This came out before azithromycin was approved for children. When azithromycin first came out, it was only approved for adults. Now it's for both. So this made this drug kind of obsolete. It was a twice-a-day drug. It was convenient. It's a broad-spectrum drug. a type of improved erythromycin. It's also the same class of drug as azithromycin, and erythromycin, a macrolide antibiotic. So it was good for that regard. It was good for substituting for penicillin, and it was only twice a day. I put all the calculations on here for it, but I don't use it anymore because it's a 10-day drug, and we can use azithromycin for 1 or 3 days in a single dose per day. So it's on here. It's in your handout if you want to see it. But I just wanted to put it up there because some people still use this drug. Cephalexin, another alternative, Keflex, brand name, cephalosporin. It's important to know that these are cephalosporins. So they are similar to penicillins, but they're not penicillins. They're cell wall inhibiting, they're bactericidal. The dosage rate is almost identical. The problem with cephalosporins like Keflex or cephalexin, they're only gram positive with little gram negative activity. Not like amoxicillin, which is broad spectrum gram positive and gram negative. So you have to know that you're dealing. So this would not be good for children, by the way, for Haemophilus. Let's just say that. But for adults with staph and strep, it's a substitute. It is bactericidal, again, gram positive, moderately effective against penicillinase, not perfect, but it does work against penicillinase producers. It's very inexpensive, generally as a generic. That's the only way you'll find it in pharmacies these days. It's an option for penicillin sensitive patients, but remember this. 3% of patients who are penicillin sensitive will also have a crossover sensitivity to the cephalosporins, and it has low GI side effects. Indicated for exactly the same things as augmentin, except not effective against gram negatives like Haemophilus. So don't use it in kids. Dosage forms 250 and 500 milligram capsules. Don't use the 250s anymore. It used to be a choice of 250 or 500 QID in adults. Because of resistance, I don't use the 250s in adults. It's 500 milligrams, more convenient TID. That's my standard dose for adults. And we use 125 and 250 suspension, same as amoxicillin, same concentration. This was I used to go to the ER a lot. I was on call for Loveless Medical Center for 25 years. And this is a blowout fracture. You can see you're looking at the patient essentially, their left eye on your right side view, looking at it, you can see black. That's air. You can see the orbit is black and the sinus underneath, the maxillary sinus is black. And you can see the orbital rim that divides the two is intact. On the patient's right, your left side is a blowout fracture of the orbital floor. Whether this patient needs surgery or not, some things heal on their own. The smaller fractures, the lamina cabrosa fractures usually don't need surgery, but this is a full blowout fracture. You have blood and muscles and everything junked down in the maxillary sinus. You have communication between the sterile orbit and the filthy sinuses where all the bacteria is, basically the filters of the head, vacuum cleaner filters of the head. And so we have to protect against an opportunistic infection. ER doctors really liked when I prescribed Keflex for this, 500 milligrams TID. Could I use augmentin, and do I now? Yes. Could I use azithromycin? Yes. But Keflex seems to be what ER doctors like you to prescribe, so I make them comfortable, and I would give them 500 milligrams TID for about 14 days. It would take that long for non-surgical cases to heal, and 14 days for it to quiet down for the surgeon to actually do a repair of the orbital floor. So this is one of those situations where I would give a 14-day supply to the patient and monitor them for a secondary orbital cellulitis until they have surgery. But again, we are sending these cases off for evaluation by a facial surgeon or a plastic surgeon, or at least an ophthalmologist to repair that. So we have to get them started on the prophylactic medication. That's what it is all about. So let's talk about PEDS dosing of cephalexin if we're going to use it. Remember, it is not good for Haemophilus, but there are situations where we may want to use it for certain things like staph infection or even strep. 25 to 45 milligram, just like amoxicillin. So again, just like amoxicillin, we work at the higher end of the dosing range. This kid weighs 45 pounds, equivalent to 20 kilos. So 20 kilos times 40 milligrams per kilogram per day is equal to a daily 24-hour dose of 800 milligrams. We're going to give a TID in this case, so we divide it by 3. So each dose is 266 milligrams given TID. 250 divided by 5 means that there are 50 milligrams per cc of this drug. That's the drug's concentration. So we divide 266 milligrams per dose by 50 milligrams per cc, and we give this kid 5 mLs 3 times a day by mouth is going to give us our proper dose. Again, take your time, figure this out. If you have any questions, don't be afraid to contact me about it. Due to resistance, again, and high therapeutic index, remember cephalexins have a almost unlimited dosing range, not as high as penicillins, but it's really hard to overdose a patient with these medications. For adults, again, I said don't use the 25, it should be 250 milligram capsules. 500 3 times a day is a convenient dosing frequency, and it for 7 to 10 days is the average treatment period. If you can look at them, if you want to see some things we don't look at again, but usually patients that are bad enough with that take an oral medication, I check them at 7 days. So I give them a 7-day supply and I have them refill the medication. Or I give them a 10-day supply and have them keep taking the medication for whatever the 3 more days is another convenient thing. I just don't like having patients have excess medication laying around that they take on their own or give to other people. I think they should use it, and that's it. And if I need more, I'll give them more. Now, there are second and third generation cephalosporins you need to know about. These are okay for kids and good for Haemophilus. They follow the Henpeck rule, which you should understand, because this talks about the gram-negative pathogens. Henpeck stands for Haemophilus, E. coli, Neisseria, Proteus, Enterococci, and Klebsiella. The only thing that we generally worry about, sometimes Klebsiella, sometimes Proteus for corneal infections, but those are treated topically. Haemophilus is our big dog, which I talked about earlier. Cephridine and Ceftin are the two ones. They're BID drugs essentially, and they are for gram-negative infections. Remember, you can't have it both ways with cephalosporins. It's either primarily gram-positive, cephalexin, or more gram-negative with these second and third generations, whereas amoxicillin covers all generations. Okay, here's some examples here. Good alternative for Haemophilus and other gram-negatives. Cefuroxime, which is called Ceftin brand name. Third generation cephalosporin, twice a day dosing for gram-negatives. The dose is 15 milligrams per kilogram twice a day. The maximum dose is 500 milligrams per day, and that's for children's pediatric maximum dose. So don't go over that, even if you calculate a higher dose than that. If it's severe infections, I'm talking about life and sight threatening, they'll go up to 1,000 milligrams per day. But the run of the mill infections are capped at 500 milligrams per day. They come in 250 and 500 milligram tablets, and your option with suspension is 250 milligrams per 5 cc's, okay? And the bottle is, the size of the bottle is 50 cc's. And again, same calculations that we use in anyone else, pediatric dose. Next case, 15-year-old female presents with her mother. Now, their mother was really pissed off. She said to me, she's really upset about being in the office again. She said her daughter had seen a nurse practitioner and 2 optometrists treated with drops that include ciprofloxacin and tobramycin and dexamethasone. And she wonders why nobody can cure her doctor. And this is her daughter. She's had this red eye now for over a month. She's had it so long that she matches her fingernail polish to her eye color there. You can see beautiful match though. Very stylish. She has giant follicles. She has big preauricular node. There's some more follicles for you. So what is it? Well, we go by the statistics. Classification of chronic conjunctivitis, something that's been around longer than a month and has not responded to treatment. It would get better shortly and then just come back, is what happened in this case. Take a look at what's number one, chlamydia. For all of the other infections. And in my practice at the Kiwa Pueblo, I see at least 5 cases of chlamydia per month. As a doctor at Lovelace, I would see a case every 3 or 4 months, and that's a hospital practice. Here in our practice, we see it monthly. In the population, the sexually active population, 15 all the way up to 30. It's the average patient is 25 years old that comes in with this, and it's very frequent. When in doubt, we do a Binks. Our lab has this Binks tester, and we're not taking eye cultures, we're taking urine culture tests. They're really neat. You just do your urine test, the lab does it. It takes 30 minutes to process, so I can do it in real time. It tests for STDs, including gonorrhea, along with, it doesn't test for syphilis. If we think that they may have syphilis, or HIV, we test that separately, but it does test for the two big ones, chlamydia and gonorrhea, at very high accuracy and specificity. So this is really a handy test to have. Going forward, throw another case in like this. We have a quick case of a father like son. This is a 3 week old newborn, sudden onset within days of being born while in the hospital. Within a week, they'd left the hospital and actually gone home. I'm sorry, confusion. 3 week old newborn, after they went home from the hospital, mucopurulent discharge. Father had also had almost an identical presentation, giant follicular conjunctivitis, marked preauricular nodes in both patients. The question is, we're going to treat these patients. Who else do we have to treat? Well, let's talk about it. This is ophthalmia neonatorum. Chlamydia is the number one cause. Gonorrhea is only 1 to 5% of cases, whereas chlamydia is 32%. It's an epidemic. Chlamydia is an epidemic situation for all age groups. I'm talking about senior citizens as well. It's the number one cause of conjunctivitis. If you take care of nursing home patients, they can be abused by their caregivers. So I just want to make it clear, chlamydia can occur anywhere, and it does in all age groups. The old prophylaxis was silver nitrate, called Crede prophylaxis. The newer was topical erythromycin, being now azithromycin ointment. And now the latest is povidone iodine 2.5%, which is the newest because it works very effectively. This is important in terms of timeline of diagnosis that I alluded to earlier. The old Crede prophylaxis, everybody that got treated with silver nitrate got a red eye for the first day, right from the get-go. Gonorrhea produced while they're still in the hospital. Most people stay in the hospital after a normal birth for about a week. They don't do that anymore. Insurance companies kick your ass out, I think, about 5 minutes after the birth, if it's normal. Actually, the average is probably a day or two. I don't want to, since I haven't managed patients knowing how long they stay after giving a normal birth, how long they stay in the hospital. I'm going to guess 1 to 2 days. So gonorrhea shows up while the kid is still in the hospital, and it's considered an ocular emergency. The trouble with chlamydia is it shows up after the first week. And so the kid has already gone home, and so people aren't alert to it right away. The mother might think it's a normal red eye, pink eye usually, and may not even call the doctor, and may not be found until the kid goes in for a recheck after birth. But again, chlamydia is a late developing infection. It's the number one cause of chronic conjunctivitis and ophthalmia neonatorum. It is a sexually transmitted disease, but what happens with the mother? Well, the mother passes it on to the child. That's why mothers should be checked and treated for herpes simplex, and which is considered a sexually transmitted disease, type 2 herpes, as well as any other sexually transmitted disease, including chlamydia. It occurs second week postpartum, potentially can cause conjunctival scarring, systemic complications. The old treatment, again, is azithromycin for all orally. The new treatment is different, and I'm talking about systemic therapy. This gets a little complicated. CDC recommends for chlamydia treatment the following: both topical and systemic. Usually it's a fluoroquinolone is one option. Another one is azithromycin topically, but they have to take doxycycline. The mother does 100 milligrams twice a day for 7 days, not during pregnancy or lactation. They can use levofloxacin in an emergency. That's not used. That's the fluoroquinolone, orally, not used in pregnancy. And then they get retested. Remember to always retest your patients, okay? They take their drug, they come in after 10 to 14 days. What I do is I give them the 10-day treatment usually, at least 7, but 10 days to err on a positive side, sometimes even 14 days. And I have them come in no sooner than 14 days after diagnosis and the beginning of treatment and have a retest. If they test positive, then I'm going to have to either change the drug or extend their treatment. Now, here's where it gets dicey. This is a sexually transmitted disease. So the mother was the carrier, but the father gave it to the mother. You know, you're supposed to be in a non-sexually sharing partnership. Well, something went wrong here, and I don't know what's going to happen to the father here, but this is where it gets dicey on where this thing came from. It is a sexually transmitted disease. Everybody has to be treated again, mother, father, and child, and any other partners that might be part of this whole thing. Infants and peds that are less than 8 years old and or less than 45 kilos, or about 100 pounds, 20 milligrams per kilogram per day for 3 days. That's the double the normal dose that we give for children. As you remember, the standard dose of azithromycin is 10 milligrams per kilogram per day. Well, we double that. If they're 8 years old or older, and but also greater than 45 kilos, they get a 1 gram single dose. They can also take erythromycin 50 milligrams per kilogram per day, QID, for at least 10 to 14 days. That's why I think people prefer to take the azithromycin. And you have to remember, these things are all macrolides. So if you're allergic to azithromycin, you're probably also allergic to the erythromycin. You might get away with, as a last choice, amoxicillin in this case, at the higher dosage range. But these are the standard recommended CDC treatments. So it's going to be doxycycline for the adult, again, not during the pregnancy, but post-pregnancy management. If they can't take that, there are some alternatives as well for the adult. And preferential drug of choice, children, azithromycin. Here's the dosage calculation again for azithromycin. Child weighs 36 pounds, divide by 2.2, 16 kilos, 20 milligrams per kilogram times 16 is a daily dose of 326 once a day for 3 days. The available dosage form for this would be 200 milligrams per 5 cc, which equals 40 milligrams per cc. We divide the total dose per day by the concentration. That gives us 8 cc's. Will gives us 320 milligrams exactly of drug once a day for 3 days. The total volume for 3 days is 24 cc's. That's what we need to treat for 3 days. It comes in 15, 22 and a half, and 30 cc bottles or ml. So we're going to prescribe the 30 ml with no refills. Make sure they tell them to shake it. It is a suspension, and they're going to be able to measure the amount there with a special dosing delivery system, which I'll show you in a second. So again, let me go back again on that just to be clear. 8 mLs is going to give the kid the daily dose. So he's going to use 24 cc's for the total 3-day treatment period. Again, chlamydia in pregnant patients, no doxy during pregnancy. The option 1, azithromycin 1 gram single dose. That's 2 500 milligram tablets taken all at once. Option 2, amoxicillin 500 milligrams TID I'd give it for 10 days actually, just to be safe, because I'm seeing a lot of resistance with chlamydia these days, and amoxicillin is a safe drug. You can ask me, could I give Augmentin in the higher dose? Sure. In fact, I think 875 of Augmentin BID for 10 days would be a great alternative for this. Again, the CDC doesn't evaluate everything, but amoxicillin in a high dose, safe, twice a day, would be a great treatment for this. So you can be a little thinking outside the box even when you treat these things. Okay, so a quick case, herpes simplex. This was sent in by a PCP who thought they knew how to diagnose eye disease. And what we're looking at here is this area. Let me see if I have a circle on that. Let me go back again. This is the area in question. Look at these vesicles, right? That sounds like herpes simplex, but look at this pattern of redness. This localized redness is characteristic of staph. Staph localizes. This is not herpes simplex, okay? That area there is crusting, essentially. This is impetigo, skin infection. And how did I know it? Off just looking at the patient, a walk in the door diagnosis. It was on both sides of the face. Herpes doesn't do that. It localizes itself to one side or the other. This was all over his face, essentially. So this is a bacterial infection of the skin. It's called impetigo broadleaf. That doesn't identify the organism, which is usually a staph or a strep, usually a MRSA typing, so it's resistant. It's highly infectious. The vesicular-like lesions will mimic herpes simplex. Also, again, it can produce contact dermatitis and blepharitis. But you do have to, when I say aggressive management, I'm talking about the kitchen sink, which includes oral medications. Do not treat this locally, okay? I mean, excuse me, topically. Hygiene, bedding and clothing, disinfection. There's old and new anti-disinfectants that we use on the patient, and then the proper topical and systemic antibiotic. So let's talk about the disinfectants first. This is povidone iodine. It works well against these types of infections. It can be used in the eye in lower concentrations, but it's ionic, means it doesn't penetrate tissues. It's a surface disinfectant. Your eye, when you put this on the eye, it's like putting it on the surface of a table. It doesn't penetrate the surface at all. So all those viruses or bacteria that are maybe infecting cells are not touched by povidone. That's its Achilles heel. It causes staining, it's uncomfortable, it's toxic, blah, blah, blah. If you're allergic to iodine, you have a reaction to it. It's not eye approved necessarily. You can use it off label. It's good for skin infections, but again, nobody likes to have a purple face. And it's also used for pre-op. So there are alternatives. This one was my favorite. As I say, back in the day, Physohex, 3% hexachlorophene cleanser, it's a soapy type solution. It was used for lots of skin infections. You could clean up around the eye 3 times a day. You don't use this in the eye. This is for the skin, not for blepharitis, too toxic, short term. Avoid getting in the eye, no longer available. So obsolete. So what do we do now? Hypochlorous acid. This is one of the major clinical reasons I use this drug. I like the higher, these drugs come in a variety of concentrations. Hypochlor, specifically, I use this one because it has a higher, double the concentration of some of the more common ones that you might see advertised out there. And it's available in a drugstore. You don't have to order it from some company or online. It's available everywhere. So hypochlor is one that's used. We would spray the face 3 to 4 times a day after we do the cleaning of the face. That's good old soap and water. And then we'd spray the face with this, let it dry, and then would apply our topical antibiotic, which we'll talk about. These are the topicals. Bacitracin is okay. It is an old-fashioned one that's specific for gram-positive, which is staph and strep. Ciprofloxacin ointment can also be used. It's an ophthalmic ointment. It can go in the eye as well, which is good. But I would use a ciprofloxacin drop on the eye, and I would add to it the ciprofloxacin ointment to the skin. But even better is a product that's designed for gram-positive, specifically infections, is called Bactroban. That's the brand name. The active ingredient is mupirocin, and generically it's mupirocin cream or ointment. I like the cream for around the eye because it's not greasy. You can prescribe either one. It comes in fairly large tubes, 15 to 22 grams, which a person is not going to use in their lifetime. But it's an interesting, mupirocin is an antibiotic activity compound that comes as a natural product secreted by, just like penicillin is secreted by mold, Pseudomonas secretes mupirocin. What it does is it clears its territory of competing gram-positive organisms. Pseudomonas is a gram-negative, so it tries to kill the competition off. And so this compound is derived from Pseudomonas, specifically active against gram-positive organisms like staph and strep. This is what we're dealing with Ampetigo. It will be applied 3 times a day to the lesion. So first clean the lesion, use the topical eye drop, spray on your hypochlorous acid, let it dry a little bit, and then rub in your Bactroban to the lesions around the eye. If it gets in the eye, it's all right. It's not going to, it has no toxicity to the eye, but it's not approved for eye treatment. Management treatment of impetigo. Again, the cause, as we mentioned, gram-positive. Hypochlorous acid is your disinfectant. Bactroban is your topical for the skin. Fluoroquinolone, like moxifloxacin, can be used around the eye in the fluoroquinolone in the ophthalmic form, and as an eye drop TID. Remember, this can be mistaken for by you or by someone else as herpes simplex. Remember that it doesn't honor the single side of the eye. It can go anywhere in the face. That's the first giveaway. And use the appropriate oral antibiotic, which is what we're coming to now. So what is the drug of choice for this? It's azithromycin. For kids, again, the standard dose is 500, adults is 500 milligrams a day for 3 days. For kids, it's the 10 milligram lower dose that we talked about earlier, not the 20 milligram chlamydia dose. You can use augmentin, but it's not as effective against MRSA, which most of these organisms are methicillin resistant if they're in the staph family. If you do use it, use the higher dosage at 875, and you should use it for 10 days. If MRSA, you can give orally Bactrim DS if they can't take azithromycin is an option for you. Bactrim is a sulfa a trimethoprim combination, comes in oral pills as well as liquid. We'll talk about that. Another drug we're going to try to cover is clindamycin. Remember this about clindamycin, it's an oral medication for children and adults, but not for pregnant patients. It major side effect is pseudomembranous colitis. You should know that. Anybody who takes this and gets diarrhea has to be seen immediately, stop the drug, and tested for pseudomembranous colitis, which is Clostridium difficile, super infection of the gut. But it's a very effective drug, very effective particularly against gram-positives. It's very specific to gram-positives, actually. And doxycycline, avoid under 8 or pregnancy, is another treatment option for impetigo. But the drug of choice is azithromycin. The folic acid inhibitors I alluded to just a second ago, which is Bactrim, which is a combination of sulfamethoxazole and trimethoprim. These drugs, the bacteria have to produce their own folic acid. They don't take it from their environment. Humans take it in from their environment. So bacteria, in having to produce it, have to take the raw material and then produce it, turn that into trimethoprim. There's about a 3-step process that bacteria do that. Trimethoprim and sulfa are able to block 2 subsequent corresponding pathways. So it's very effective in inhibiting folic acid synthesis. That means that this is not a bactericidal drug, it's bacteriostatic. So it suppresses growth, doesn't kill the organism, but it is a good treatment option for this if you can't use the other drugs. It is effective against MRSA, though that's what makes it important. And it's not a penicillin, of course, and it's not a macrolide antibiotic either. It's a folic acid inhibitor. Sulfa must always be used with trimethoprim. You have to have that combination synergism. Sulfa by itself is a crappy drug, doesn't work well. And remember, the trimethoprim is not a sulfa. So if you're using drugs that contain trimethoprim, like polytrim, it is safe in people with sulfa allergies. It's a folic acid inhibitor, but not a sulfa like sulfamethoxazole is. So keep that in mind. In adults, we use the double strength preparation because of resistance. The double strength tablets contain 800 milligrams of sulfamethoxazole and 160 of trimethoprim. Now remember this, when we calculate a dose for pediatrics, we consider the active limiting ingredient to be trimethoprim. So that's what we use as when we calculate pediatric dosing. The suspension contains 200 milligrams of sulfa with 40 milligrams of trimethoprim in every 5 cc, and we pay attention to the trimethoprim limiting dose for toxicity. So the dose is 8 to 10 milligrams of trimethoprim per kilogram per day in divided dose every 12 hours. We'll show you the example. 7-year-old 50-pound male with periocular impetigo, no allergies, cultures as MRSA. The drug of choice is going to be Bactrim in this particular case because they can't take azithromycin. They're allergic to it. People are, for example, or because it's MRSA. That's the other reason we would go to this. 200 milligrams per 40 per 5 milliliter dose. Pediatric dosage based on trimethoprim. We divide the kid's weight by 2.2, so he weighs 23 kilos. 23 times the trimethoprim limiting dose of 10 kilogram per milligrams per kilogram per day is a dose, 24-hour dose of 230 milligrams of trimethoprim divided by 2. He's supposed to get 115 per dose twice a day. We know that there are 40 milligrams of trimethoprim per 5 cc's equals 8 milligrams per 1 ml. So we divide the dose by 8 milligrams per ml gives us 14 mLs to come up with a 115 milligram dose, which is given twice a day. Again, don't use teaspoons or tablespoons. You have to be very precise. Oral syringes or an oral cup measure is going to give you an accurate reading. No tablespoons, no teaspoons. This isn't grandmother's house. This is a medical facility type of dosing. These drugs are too potent to take chances with. So the prescription, sulfamethoxazole trimethoprim oral suspension, 300 cc's, because we're giving the kid 30 cc's a day, times 10 days is 300 mLs. That's how we calculate. You got to give the right amount of drug dispensed. We don't refill this. Like I said, I want to make sure. And we tell the patient to shake the drug because we do not want all the active ingredient to sit at the bottom of the bottle. Two unpredictable sulfonamide risks are allergy and Stevens-Johnson. It is important to note that the only other indication for sulfa as a primary drug is toxoplasmosis, so it is still an important drug. And it is, again, an alternative for treating MRSA type infections orally or people who can't take the other drugs. We don't give to pregnant patients because it can cross the placenta and it is a folic acid inhibitor. It can, and folic acid, not having folic acid causes some birth defects. Mothers are supposed to take oral folic acid, but again, remember, no sulfas in pregnancy because the fetus can be allergic to the drug when the mother is not, based on the father's DNA. Do not give it to a sickle cell patient. It can cause sickling, all right? That's the other major contraindication. And again, only use sulfas with trimethoprim. You need that synergistic combination. This is an example. I treated a patient who was a nurse who had been exposed to a drug, not a sulfa, but another drug, that she was having seizures, was taking a seizure medication that caused this reaction. We don't use steroids in this situation, but you can get corneal scarring in these patients. So they always have ocular complications, but even more importantly, Stevens-Johnson can be life-threatening. And that's the major downside. Now, let me give you a clue here. One of the questions I ask patients before I give them sulfa medications is, has a medication ever caused sores in your mouth? That's stomatitis. And if they say yes, do not give them sulfas because their chance of having a serious reaction, the Stevens-Johnson reaction to any of the drugs that cause Stevens-Johnson is very high. So if they just say sores in the mouth, I do not give it to them, all right? Keep that in mind. If they just took one of these drugs and had a rash, never give the sulfa medication in that situation. Another forgotten antibiotic are the fluoroquinolone orals. I'm not talking about topicals. I love the topicals. I use them in all age groups. Good for gram-positive, good for gram-negative. They kill everything. They're miracle drugs. But in oral situations, I've used them maybe 5 times in my career. And that was only when the patient was allergic or couldn't take anything else that was indicated for their problem. Never to a pregnant patient. No, what it does is interfere with collagen formation, connective tissue, can cause all types of issues in a fetus. Also, not in pregnant because, again, you expose the fetus to the drug. It can also cause neurological conditions like seizures in adults, even. So be careful about a seizure history. Not the kids under 16, they're still growing. Elderly males, in particular, are prone to Achilles tendon and bicep tendon ruptures from this drug. So it has all types of issues with the oral dose, but it works really well. It's really good for bladder infections, prostatitis, etc. It's used in large measure for that. And below the waist step infections or septicemia, or a secondary drug if they can't take the primary drug. But remember, there's all types of contraindications with the fluoroquinolones. And again, remember, Achilles tendon rupture is a biggie in elderly adults. The only pediatric indication for these drugs is anthrax and plague. And I don't know about you, but I haven't treated one of those lately. So again, very rarely would I ever use this. I have never used this in a child, only in adults and only sparingly. If this was my only choice in a child, I would refer them, by the way. Clindamycin, I talked about that earlier. This is an excellent drug for resistant severe gram-positive infections. But again, I said severe when everything else fails or doesn't work, all right? or it's, excuse me, that they can't take anything else because they're allergic to it or have other contraindications. The drug works differently from all the compounds I've talked about. It inhibits protein synthesis. That means it's not selectively toxic. That means it can affect synthesis or throughout the body, and that's why it has potential side effects. But its biggest problem is secondary gut infections, superinfection, pseudomembranous colitis, which is caused by Clostridium difficile superinfection. So again, works very well for gram positives. Remember, my dog had a skin infection, and the only thing that worked for gram positives, like a dog type of impetigo, essentially, was this compound that worked well for the dog. Black box warning is there, so that means it's life-threatening. The adult dose is 100 to 50 to 300 milligrams 3 times a day. Peds get 30 to 40 milligrams per kilogram per day in a divided dose. Dosage forms, as you can see, are in tablets and a liquid dosage form of 75 milligrams per 5 ml oral suspension. I'm going to back up and tell you that I have a mistake on this slide. Forget the 30 to 40. I changed it in one slide, but didn't change it in the other. It's actually 10 milligrams per kilogram per day. Please note that. So again, we take the 65 pounder and divide by 2.2, and we get our 30 kilogram weight, body weight. We multiply the body weight times the milligrams per kilogram per day, and the daily dose is 300 milligrams per day. Divide that by 3 because that's our frequency of dosing, gives us 100 milligrams per dose. The concentration of the available product for liquid is 75 milligrams per 5 cc's. That gives us 15 milligrams for every ml or cc delivered. So we're going to divide the daily dose, excuse me, the individual dose of 100 milligrams by 15 milligrams per cc, which is the concentration, to give us the individual dose volume of 6.6. So to round up in this case, the kid is going to get 7 mLs or cc's TID for 10 days. Will give us that 100 milligrams TID dosing. Make sure that the milligrams match the volume that you give the patient. Check, double check, triple check your calculations to make sure you're giving the proper amount. This is a prescription, 75 milligrams per 5 cc of oral solution. Note solution does not have to be shaked. It's not a suspension. To give a 10-day supply, since we're giving 21 mLs per day times 10 days, 210 cc's, we want to give the largest container that we can, in this particular case, 200 cc's. So it's 7 milliliters, 100 milligrams. I always like to put the milligrams next to the volume so that we know, the pharmacist knows and can check me on this. By the way, I never have a pharmacist calculate my dose for me. It's like having somebody cut your meat for you. You look like an infant, by the way. Don't do that. Okay? They don't know anything about the eye. They know their drugs, of course, but don't ask for advice from the pharmacist. Okay? Do your own homework. That's critical. But I give them information to double check me in case they want to know what I intended to give the patient. 7 mLs equals 100 milligrams 3 times a day by mouth. Stop and report any diarrhea. Again, Clostridium superinfection is a life-threatening black box warning for this drug. I'm going to move into the last part of my lecture here, which is simplex versus zoster. I don't have a lot of time to cover a lot of any cases on this, so again, I'm just to capsulize all this so we have time for questions at the end. We're dealing with 2 types of herpes, simplex and zoster. Adults, it's pretty straightforward. Epithelial herpes, we don't use topicals for eye infections anymore. Let me repeat that. We don't use topicals anymore. Orals are all that's necessary. Acyclovir for herpes simplex is 400 milligrams 5 times a day in people with normal renal function. I didn't say hepatic because this is excreted by the kidney unchanged. Renal function is the determiner of altering the dose of this. And most children have normal renal function, adult function, by the age of 2 years. So we don't have to worry too much about that. We do have to worry about renal function, though, in general. Valciclovir, my favorite drug for this, because it's TID, 500 milligrams 3 times a day, and famciclovir, 250 TID. Now note, the only one of these three drugs that comes in a liquid dosage form for that's available for children's lower dosages is acyclovir. So you have to use acyclovir for or people who can't take pills or for lower dosages. Acyclovir is the only one in a syrup, 200 milligrams per 5 cc. For zoster, the doses are essentially doubled. So oral antivirals are safe in pregnancy and peds, as long as their kidneys are good. Antivirals are safe because they are, this is important to note, prodrugs. They are not active until they're converted into their active form, and they are selectively toxic. What does that mean? The drug gets into all the tissues of the body, but they only become active in an infected cell. Viruses produce, these herpes viruses produce the enzyme thymidine kinase. That toxifies, activates these compounds inside the cell so they're selectively toxic where they kill only virally infected cells. All the other oral antivirals that we dealt with in the past were not selectively toxic. They affected DNA and RNA. They could cause mutations and side effects and cancers. These new drugs that I have listed here are selectively toxic prodrugs. The only liquid form, like I mentioned, is acyclovir. Dosage is 20 milligrams for peds per kilogram per dose, 4 times a day for 7 days. You got to give a lot of this because it takes a large volume. This comes in a 1 liter, 1000 cc bottle for that reason, because the kid's going to get 80 milligrams per kilogram per day, and it's going to take a lot of drug, 200 milligrams per 5 cc. An adult taking this, some adults, remember, liquid dosage forms aren't just for kids. You always ask adults, can you swallow pills? And if the pill is large, like augmentin, give them a chewable tablet or a liquid dosage form. It's not just for kids. For simplex and zoster in immunocompetent, that's normal children only, not if they're compromised with HIV or something else. Peds greater than 2 years get 20 milligrams per kilogram per dose 4 times a day for 5 days for any of the herpes infections, cold sores, whatever, or chicken pox, etc. 12 and older adult dosages of the antivirals. Remember, that's because the kidneys are developed very early in life in children, not the liver, but this doesn't depend on liver metabolism. If less than 2 years, must be hospitalized for IV use. Remember, herpes simplex can go, particularly newborns are at great risk because they can develop meningitis from herpes, which can kill them essentially, or cause neurological deficits. So what do we watch out for? As I said, renal function. Antivirals, if a person becomes dehydrated, their urine gets more concentrated and these compounds can crystallize and damage the renal tubules inside the kidney. So number one, make sure that the person takes a full glass of water with their dose of medication. And if they exercise, keep them well hydrated. Or if they work, they sweat, make sure that they stay well hydrated while they're taking the medication. If they have renal disease, the drugs can still be used, but it's important. I didn't put it in here because the dosing calculations depend on situations where there's really low renal function. For example, your renal function can be at 50% creatinine clearance, and you still use the normal dosages. But once you get below 50% renal function, then the dose is either adjusted downward in the amount of drug you give, or in the frequency, or in people with a creatinine clearance of almost zero, stage 4 disease, it's like once a day, half the dose. But again, if you need to look that up, you certainly can. Well, I think we finished just about on time. I'm surprised I hadn't practiced this fully. I've just updated this lecture, but I had a blast giving it to you. I certainly prefer doing these things in person. I hope this is useful, relevant, and practical. And I want to thank you for that. And I'd be willing to take questions at this point in time. How's
That
that
was
for being on time?
That was amazing. I was just about to turn my camera on. I said, I'll give him another minute. I mean, you get the award for the best timing yet. Usually, I know as a speaker, sometimes I feel like in the beginning, I never think I'm gonna have enough material. And then by the end, you're like, there's no way I'm gonna get through all this.
Always, 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 never short.
Always, but that was perfect. And we do have some questions. So, as a reminder, if you have questions, I know that a few questions have come in over. Um, the hour and 40 minutes, but please put some more in there. And we're getting some also wonderful comments thanking you for a great lecture. So I would like to say as well, that was fantastic. It was very helpful, very informative, and I love the cases that you sprinkled in to help drive the message home. Good morning, Dr. Lonsberry.
Good morning. How are you?
Good, how are you?
I am excellent, thank you.
It's
It's good to
morning
see
for you,
you.
right?
Sorry?
It's morning for you,
It is
right?
still morning for me, yes.
Well, I can't think of anyone better to round out our weekend of pharma. So this is going to be awesome.
It's always a pleasure to be here. It's good to see you as well.
It's good to see you. I was going to say this is a couple times I get to see you live in the fall right after virtual the same week. So
Yeah, you very much surprised me when you texted me and I was you're here? Didn't you already hear all these lectures already?
I did. I said I'm ready. I'm ready to answer the questions and be ready.
I did check your answers though. You didn't do so well.
Well, I can't promise I'm always listening. So. Well, let's get started. So I know that there are a lot of people here very excited. This is our fourth session of the Cozy Pharma Weekend here at Wu University. One of my favorite events. I love it. And in Connecticut, it's actually pretty nice out today. I'll say 40 degrees is nice after it's been really cold. So no better weekend than to cozy up and get some CE. But I'm excited to finish off the day and the weekend with you. So welcome to Contemporary Pain Management in Optometric Practice with Wu favorite Dr. Blair Lonsberry.
Well, thank you very much.
You're welcome. And I'm still your host. So just a reminder, for each hour of CE, attendees must be online for a minimum of 50 minutes. For this course, that will be an hour and 40 minutes. This is a 2-hour course. Please fill out the survey link in the chat for your COPE certificate. The survey link will also appear when the webinar ends. Those CE certificates will be delivered by email and sent to ARBO with your OE tracker numbers. The QR code will be displayed at the end as well if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. And a reminder to use the on-screen floating panels to ask questions throughout the presentation. We'll leave about 10 minutes at the end to take care of those. And there's your mobile device, where to find the chat and Q&A. So I get the opportunity to once again welcome and introduce Dr. Blair Lonsberry. He grew up in Rossburn, Manitoba, Canada, obtained his optometry degree from the University of Waterloo in 1996 after completing a Master of Science in Physiology from the University of Manitoba. He completed his residency in primary care optometry from the Illinois College of Optometry in 1997, then joined the faculty at Southern College of Optometry in Memphis. During his time at SCO, he completed a master's in education degree with an emphasis in adult learning. He currently is a full professor with Pacific University College of Optometry in Oregon, where his primary teaching responsibilities are supervising interns and overseeing a specialty lumps and bumps clinic. In his spare time, he goes to Anchorage, Alaska, where he sees patients in a private practice. And he has 2 white German Shepherd dogs named Bo and Bennett who keep him sane. Is it still just 2?
Yes. Well,
Okay.
we were doggy seeing 2 other dogs, and we actually unfortunately lost Bo just a couple months ago. So I need to
Oh.
update my bio, but yes,
And we
we
did
still
see
have that
Bennett in the
dog.
picture this morning. I think that
Yeah.
was
So
Ben and Matt.
I sent a picture of Bennett this morning. He usually hangs out with me,
He's ready to learn about
ready
pharma.
to learn.
He probably knows more than most ODs after listening to this week. Dr. Lonsberry is a diplomate of the American Board of Optometry, a fellow of the American Academy of Optometry, the Optometric Retinal Society, and the Optometric Glaucoma Society. Welcome again to Woo You. I'm going to turn it over to you, and I'll see you at the end.
Thank you very much. Good morning, everyone. We are going to be interactive. If you've been to my presentations before, we are going to be interactive. If you have any questions, feel free to email me at blonsberrypacificu.edu. I'm happy to answer questions for you. If you want copy of my handout, I'm happy to send that to you as well. So let's get you warmed up here. So if you wouldn't mind logging into my poll everywhere. So just click on the, or use your phone, click on the QR code there. That should log you into the Poll Everywhere. You do not need to be logged in to get any credit or anything for the lectures. It's just to have some interaction going. All right, hopefully I've got a few of you logged in. When the questions come up, you can still have the opportunity to log in there. So we are going to do contemporary pain management. I think pretty much most of the states have the ability to prescribe some form of pain medication. Well, now whether or not you can get into the opioids is probably a different question, but ultimately I think our patients still need to have pain management. And I think it's important for us, particularly in this era of an opioid epidemic, that if we are prescribing any of the opioids, that we do it responsibly. And I do think that there's certain instances where we do need to prescribe opioids, but I think that there's other ways that we can help manage patients' pain without having necessarily to go into the opioids. So we're going to look at addiction, substance use disorder, some of the reasons behind the whole opioid epidemic, and then we're going to talk about pain management. We're quickly going to talk about topicals. We won't spend a ton of time on that, and we're going to spend most of our time talking about orals, and then also if you're going to prescribe opioids, responsible prescribing for opioids. So when we talk about pain management, we talk about asking patients their pain scale. And I think this is probably the most common ones. I see this in my physician's office, usually going from a ranking of 0 to 10. Now, we do have to be mindful of the fact that someone's 6 may be my 10 or vice versa. And we have to kind of gauge certain patients' pain on the presentation that they have as well. We do know that there's certainly patients out there that are seeking pain medications. And in particular, we get a little bit concerned about patients when they come in and they have a very specific, agenda saying, this doesn't work for me, this doesn't work for me. The only thing that works for me is, morphine or oxycodone or whatever. So I think we do need to be aware of that. I did find this one. I thought this was quite amusing. Might be another way for us to kind of do pain. I particularly like number 9, mauled by a bear or attacked by ninjas. Probably a bit more of amusing pain scale. I'm not too sure it's really practical in your office, but I did find that amusing. So with the opioid epidemic, this really started in the late 1990s, where pharmaceutical companies at that time said really that there's no chance for addiction with their opioid medications. And at that time period, most opioids were prescribed for patients who had cancer and end-stage cancer. And at that point, there was really very little chance for addiction because ultimately patients who had end-stage cancer didn't necessarily live that long. And no one was going to necessarily tell a patient who had end-stage cancer that, no, we're not going to give you pain relief. It was really at that time where the pharmaceutical companies were indicating that there's really not a huge chance for opioid addiction and that we should be prescribing it for more conditions. So things like now be prescribing it for osteoarthritis or lower back pain, these chronic conditions where patients are likely going to take this medication for long periods of time, dramatically increase the chance for addiction. So the increased use of these medications for conditions where patients could potentially use them for a chronic period of time really was the beginning of the opioid epidemic and realized that they actually were highly addictive. In 2017, the Human Health and Services declared a public health emergency with respect to the opioids because they basically were spiraling out of control at that point. So what do we know about the opioid crisis? Roughly upwards of 30% of patients prescribed opioids for chronic pain misuse them. We have to remember that with the opioids, particularly things like oxycodone, that they really don't manage the pain. What they do is make you not care about the pain. So they actually bypass the body's normal response to pain. They just kind of reroute it around it. So ultimately, when the pain med wears off, it's not managed that pain at all, and the patient's back into pain. So they go back and take another opioid because the fact it makes them not care about the pain. And that's a very powerful incentive to continue to take the medication because not only are you out of pain, but there's that kind of euphoric feeling of the fact that you really don't care about the pain anymore. And people do not like to be in pain. So ultimately, they're much more willing to continue to take this to not ever be back in that pain. Between 8 to 12% of people using an opioid for chronic pain develop an opioid use disorder. And approximately 6% of who misuse prescription opioids transition to heroin. So this was what we call basically a gateway drug. that most patients who, 80% of patients who, use heroin first misused an opioid prescription, and they just built into something more powerful. And we'll talk a little bit about the mechanism behind that, but ultimately what happens with the opioids is that they end up changing dopamine levels in the brain. And dopamine is really linked into that pleasure part of our brain. So the likelihood of developing an opioid use disorder depends on many factors, including length of time person is prescribed to take the opioid for acute pain, length of time that people continue to take the opioids. So again, it's really an interesting battle between, are we going to manage the pain to the best of our ability, which is really kind of making them not care about the pain, and that chance for addiction as well. And we have found that patients can become addicted to opioids within 4 days of them starting to take the medication. And so there's not a lot of time before we have to realize that patients have a potential to become addicted to these medications. So here's my first question for you. Again, if you didn't log in before, that little QR code is up in the top. But a change in behavior caused by the biochemical changes in the brain after continued substance abuse is termed as what? All right, let's see what people are thinking here. And the correct answer is C. This is substance use disorder, or what we used to refer to as addiction. The new term really for addiction is substance use disorder. When we talk about dependence, dependence is your body's response to a drug. And so that's where the withdrawal symptoms come from, is your body becomes used to that medication and it sets up a certain physiological response. And when that drug is taken away, then that physiological response responds to that, where people get, they get to start to sweat, they get nauseous, they get headaches, etc. Tolerance is what happens to certain drugs where you end up needing higher and higher amounts to get the same effect. Now, tolerance really does happen with your opioids. It doesn't happen with things like, aspirin or NSAIDs or acetaminophen. It happens where there's potential change in biochemical processes in your brain. And so tolerance is what we find with patients who have an opioid addiction, is that they start taking maybe one oxycodone and that was fine, but then to get that same effect, you need to take 3 or 4. So tolerance is your body's basically becoming adapted to that medication. Withdrawal is what happens physiologically when you remove that drug from the system. And that's mostly why patients don't want to stop taking an opioid once they become addicted to it, because those withdrawal symptoms can be quite severe. In particular, there's lots of mental processes that go on it. Patients become really paranoid. They start to get nauseous. They get sick. They get the shakes. Basically, kind of like DTs. They're going through withdrawal syndromes. So the term dependence typically refers to the physical dependence on a substance. Generally, quickly after that's going to become addiction. So once your body starts becoming used to that medication or dependent on that medication, then we get into the mental process of addiction. And addiction really is a mental process. It's where people end up changing behaviors because of biochemical changes in their brain. So usually the first response to people is becoming dependent on a medication, and then the next step is the change in behavior, which we tend to refer to as substance use disorder. Withdrawal is what your physiological response to when the drug is removed from the system. And you typically have to have drug dependence first, and then when you remove it, patients have a whole wide variety of symptoms that can happen with that. It includes anxiety, sweating, vomiting, diarrhea. Patients become extremely paranoid. There's a whole gambit of things that patients can go through. And ultimately, if patients were able to kind of get through that process, in other words, if they are able to, spend enough time adapting to that, they would potentially get through it. But these symptoms can be so severe for patients that they just never want to go through that process. So they much rather take the medication again to feel good, to feel euphoric, to feel powerful, as opposed to what they feel like when they're not on the medications. The time to withdrawal is really dependent on that medication as well. So it depends on which opioids are being used. So the difference between heroin could be very different than taking oxycodone. That could be different than, marijuana. So all these withdrawal symptoms can be very dependent on which drug they took last. So tolerance is where the person no longer responds to a drug in the way that they did at first. So originally they could take maybe one oxycodone and get that kind of high or euphoria that they got. Then it's going to take 3 or 4 to get that same effect. So your body actually starts to downregulate receptors in the brain to respond to these drugs. And at that point, if before there was 100% of receptors were activated, now there's potentially 50%. So you're going to need double the amount of dose in order to get that same effect that they first started off with. And this is a gradual process that happens over time. And the more they take the drug, the more those receptors are downregulated. Substance use disorder or addiction. This is an uncontrolled use of a substance despite harmful consequences. I don't think there's anyone out there who is addicted to heroin or cocaine or alcohol, etc., really thinks it's good for them. They do understand that what they're doing is harmful to them, but they continue to do it anyway. And it's what's happening is that these addictions or substance use disorders is changing parts of their brains that make logical decisions. And it really kind of derails that. People take the drugs saying, I can control this, I can take care of this, I can stop whenever I want to, I need this in order to function. And it really rewires that part of the brain that makes those rational decisions. They do understand that taking the drug is not good for them, that it's potentially harmful for them, and they continue to do it. And that's the challenge with this one, is it rewires that brain of making logical decisions. I think people think about people who are taking drugs saying, well, you should just stop. Just go cold turkey and you should be able to stop. And it's just not that easy because those brain processes are rewired. And they basically can justify anything in order to continue to take the drug because their brain is saying that they need to take it. We tend to refer this to as addiction. They're defined as chronic relapsing brain disease. And I think that relapsing brain disease is important. Even in patients who are technically been clean, those pathways in their brains are already wired. So they basically need one hit of a drug again to have those pathways reopen. So effectively, once you have an addiction, you always have an addiction because the pathways in your brain are wired. It's very easy for them to basically fall off the wagon because of the fact that as soon as they do, those pathways are already written and they just need to be reactivated. So it is a chronic relapsing brain disease. In other words, when patients have been clean, they still doesn't mean that they don't have that addiction. They absolutely do. They're just not currently taking the drug or alcohol or whatever they were addicted to, but it's very easy for them to start again. Individuals who have received opioids as analgesics only rarely develop addiction. So those people who are taking the medication because they had surgery, they're taking it for the management of pain for short periods of time, very rarely will develop addiction. Is patients who are taking it for recreational purposes that are much more likely to develop an addiction. So why do people take drugs? And there's really 4 main reasons why people take drugs: to feel good. These drugs that are being abused give the people a sense of high, really a sense of power, self-confidence, increased energy, and they like who they are on drugs. It could be when they come off the drugs, they don't feel very good about themselves. They may not feel very powerful or in control. And the drugs give them that high where they feel that they're basically invincible. And who wouldn't want to feel that way? To feel better, some of the drugs that are abused, particularly ones that reduce stress and anxiety, so say something like Xanax, can help reduce symptoms of fear in, say, going out in public. So people say the only way that they can basically be in public is if they take their Xanax, which controls, anxiety. And it could get to the point where psychologically they just need to take the pill in order to feel good. Certainly, I think the pill probably gives them that sense, but it could be even just a psychological process of saying, if I don't take this pill, I can't function. To do better, these are usually your performance enhancing drugs, things like anabolic steroids, things like Adderall, probably one of the most abused drugs, probably in university, college age students, because the fact that they take it to pull an all-nighter just to have that energy. It's the importance is for them to feel better or to do better. So do better academically, athletically. The last one is curiosity or because others are doing it. This is really crucial typically in the teenage years. They found that our brains are still developing until we're probably late 20s, or sorry, late teens, early 20s. And with the brain still developing at that point in time, if kids get a chance to try drugs, it's part of that developmental process where now their brain gets rewired for it. And it's really a powerful incentive for peer pressure, taking the drugs because others are doing it. This is where we tend to find a lot of problems that develop is typically in those 15 to 17 age range. If they're exposed to drugs at that time period, there's a very easy chance to develop addiction, which can be very hard to manage for the rest of their lives. So initial decision to take a drug is typically voluntary. It's probably not common that people are, held down and forcibly made to take drugs. It's a voluntary process. Again, it could be for, recreational purposes, but when they're typically taken for pain management, secondary to some type of procedure, then generally people will understand that they don't need to continue to take those meds. It's when they do it for chronic conditions like back pain, osteoarthritis, or they take it because other people are taking it, then that's a much greater chance for them to develop an addiction to it. The tough part about this is that we really don't know who's going to become addicted to a drug. And people who have addictive personalities or potentially have addictions to other, like alcohol or cigarettes, etc., they do have a greater chance of potentially becoming addicted to an opioid as well, because there's already that addictive personality components to it. So brain imaging studies have shown that there's definitely a difference in the brain activity in patients who are addicted to drugs versus those who are not. And really what we're talking about here is dopamine. And dopamine is part of your brain that's really linked into the pleasure centers of your brain. We are wired to repeat pleasurable experiences, and we are wired to avoid painful ones. And we talk about, putting your hand on a hot stove, and, at some point, some kid has to try it because they really don't know what you're talking about until they experience the pain and realize, well, I don't want to do that again. But we're wired to repeat pleasurable experiences. And in this case, you can see while eating food that there's a release of dopamine. So food gives us a sense of pleasure, in particular things like chocolate and sugar and etc. Are very pleasurable experiences, and our brain is wired to repeat those. When you give someone cocaine, as you can see in that picture on the right, there's a massive release of dopamine, and it really overwhelms the brain. It's like taking a bullhorn and yelling in someone's ear. Yeah, they can hear you, but it's a way too high of a level. So the brain starts shutting down those receptors, saying this is way too much stimulation. I can't handle this. So I'm actually going to downregulate the amount of receptors that can respond to dopamine. So at that point, if you downregulate those receptors, you used to have 100%, now you only have 50%, then a person needs to take more and more drug to get to that same effect. And that's where this addiction process happens. And this downregulation of dopamine can happen within 4 days of taking the drug. Their brain just starts to say, this is way too much stimulation. I don't need all of this, so I'm going to downregulate that response. When we have talked about people quitting smoking, there's always concern that people put on weight. And the thought is that there's kind of an oral fixation after people stop smoking, and it's kind of linked into this dopamine level. Food gives us the sense of pleasure. Nicotine can kind of do the same thing. So when people stop smoking, they replace it with food because it gives them the same stimulus of dopamine and that sense of pleasure that they get. So ultimately, yes, there's an oral fixation with it, and it's because they're trying to simulate that pleasure that they were getting from the nicotine that they had. So these are PET scans of two different brains. You can see the healthy control on the left and a patient who abuses drugs on the right. And this is in a state when a person is not taking any drugs. And you can see that on the right, the PET scan is just much diminished in color or illumination. And that tells you that the patient, when they're not taking drugs, is in a very flat effect. If those levers of the brain are stimulated, that means that there's more activity going on. They're processing things. They're excited about things. And so patients, when they come off the drugs, are just everything's very flat for them. Nothing excites them. Just it's very depressing, and they don't want to be in that state. So they end up needing to take the drug in order to get back not even to the normal level, but then to the high that they wanted. So people really want to avoid that flat feeling that they get if they stop taking the drug. Just nothing excites them. Nothing is interesting. So why would you stay in that state? Let's take a drug and get back to at least normal, if not back to the high that they had. So which of the following group of medications, when combined with an opioid, is one of the leading causes of death in patients? So if you're ever to prescribe an opioid, you're going to go into a drug monitoring program, a PDMP. Which of these groups of drugs are you looking for to make sure that they're not taking potentially because there could be a bad reaction between the two? All right, let's see what people are thinking. And the correct answer is B, your benzodiazepines. And why is because these are sedative medications. One of the major downsides or side effects of the opioids is they shut down respiratory centers. When people are awake or conscious, they usually can remember to breathe. However, when they go unconscious, they can't remember to breathe. And benzodiazepines, and particularly things like Xanax or Valium, are sedative medications. So people go to sleep, and at that point, the respiratory centers shut down and they don't live. That is how the actor Heath Ledger died. I was lecturing to students recently, and I mentioned, that's how Heath Ledger died, and they went, "Who's Heath Ledger?" I'm going, "Oh God." I'm just telling me that I'm old, but not that he did it on purpose, but Heath Ledger had taken some pain medication for like lower back issues, and then had an issue sleeping, and he ended up taking a combination of medications that he just went to sleep and didn't wake up. And so this is one of the groups of medications that's really concerning for people who are on opioids, is taking anything that's potentially going to make them go to sleep. So any sedative medication, that point when they go unconscious, they stop breathing. So most commonly abused drugs, marijuana certainly is one that's up there. A lot of states, like particularly Oregon, California, Colorado, has legalized marijuana. In some ways, I thought was good because I didn't have patients coming to ask me for their, green card so that they could use the marijuana for their glaucoma. Even if you told them it really wasn't going to help manage it, they're going, still want to take it. So marijuana is one of the more abused drugs. When it comes to prescription drugs, it's really your opioids, things like OxyContin, Vicodin, anti-anxiety medications such as Valium or Xanax, and then your stimulants such as Adderall or Ritalin. Those are really the drugs that primarily are abused from a prescription perspective. Interesting enough, when it comes to over-the-counter medications, it's not a medication you probably would think of right off the bat. One of the most abused over-the-counter medications is actually antidiarrheal medications. And you're kind of going, antidiarrheal medications? That doesn't seem like a medication that people would want to abuse. And why? It's because it has loperamide in it. And loperamide is actually a derivative of an opioid. And so it still gives you potentially that bit of that high. Remember, one of the side effects of people taking opioids is constipation. So for people who are long-term wise on constipation, have to have some type of stimulant in order for them to not become constipated. So Colchase, stimulant in order for them to, a laxative in order for them to be able to go to the bathroom. Prescription opioids can be used to treat moderate to severe pain, often prescribed after surgery or injury, for health conditions such as cancer. And again, really when it was prescribed for things like cancer, there wasn't much chance for people to develop an addiction. And even if they did, no one was going to say, well, you're in stage 4 cancer, I'm not going to give you pain medicine. It's really when those medications were used for long-term pain, so such as lower back pain, osteoarthritis, that really the risk for opioid addiction dramatically increases. Ultimately, people are able to take the medications for long periods of time. When we talk about algorithms now for treatment of osteoarthritis, opioids are no longer even a part of the algorithm anymore. They used to be kind of when people weren't able to respond to anything else, they would consider opioids. If you look at the algorithms for osteoarthritis, opioids are not even part of that mix anymore because of the concern for addiction, because of the potential is that they can use it for long periods of time, and there's a very high chance to become addicted to them at that point. When we think about people abusing drugs, it's not that they're taking that oxycodone and swallowing it. When we think about how drugs are processed, in particular, drugs that are swallowed, they have to go through a whole biotransformation process. So you have to swallow it, has to get into the gut. The gut is not a very nice environment for most drugs. Because of the pH in the drug, it breaks down a lot of medications and they're not allowed to be absorbed in that system. So a lot of medications then are kind of processed into the intestines where there's a 1,000-fold increased chance for them being absorbed. But once they're absorbed into the system, they go into what's called the hepatic portal system. They go through a hepatic portal vein into the liver, and the liver is your processing center. It's your detox center. So it goes through what's called first pass metabolism through the liver before it gets into the circulation. What gets into the circulation is called bioavailability. So if you take a 100 milligram pill and 70% of that or 70 milligrams gets into the circulation, then bioavailability is 70% of that medication. However, that bioavailability is typically a lot lower than 70% of what's taken. And that's what pharmaceutical companies spend a lot of time in their clinical trials is trying to find out what concentration of the drug given as a pill is going to end up in the circulation in order for it to be effective. And we have to remember that these dosages that are given for medications is kind of on a scale of the average individual. And it could be, you're above average. And at that point, maybe the bioavailability is higher or lower. And it's also comes down to what we call your pharmacogenetics. In other words, your individual ability to process medications or deal with medications is individual to you. So a certain dose for you might be more bioavailability or less. And we don't necessarily can predict that until you take the drug. So medications that are taken that route probably have a pretty low chance of being developing addiction. A much higher chance is if you get bioavailability up closer to 100%. And so people who are abusing drugs don't swallow them, they crush them so they can either be snorted or they can be injected. At that point, you're increasing bioavailability to 100% because you're bypassing the hepatic portal system. And so when you crush them and snort them, it gets into the circulation in your nose. Sublingually does the same thing. That's why nitroglycerin is used sublingually. Nitroglycerin is almost 100% broken down by the gut. Nothing gets into the system. So the best way to do that sublingually gets into the circulation immediately. The best route is obviously via an injection. At that point, you have 100% bioavailability. The downside to medications that are taken via IV, yes, 100% bioavailability, but there's almost zero chance to counteract those medications. So that's why people will die from drug overdoses. There's very little chance for you to counteract that because 100% of that drug gets into the system. Much greater chance to reverse the process of a drug that's swallowed versus something that's taken via an IV. There is also a misconception that people who are prescribed the drug means that it's safe, right? So if you're prescribed a medication by your physician, then it must be safe. Well, ultimately, that's not necessarily the case, right? It's dependent on how long you take that medication, what your own response to that drug is, and whether or not you have any other factors that might increase your chance for an addiction. So the most common drugs that are involved with prescription opioid overdoses include things like methadone, oxycodone, hydrocodone. My clinic used to be in downtown Portland. It's now since closed, but we used to have a lot of patients come from local community health centers, and we also had a methadone clinic near our clinic. And I did have a patient come in one time, gave her a new prescription. She had a fair amount of astigmatism, and she wrote me a very nice letter asking if I could increase her methadone prescription because she was having a hard time adjusting to that dreaded astigmatism. I went, yeah, I think you're going to have to rough this one out. First of all, I can't prescribe methadone, but it was a very nice letter. And she thought her dreaded astigmatism that she needed an increase in her methadone prescription for that one. Overdose rates were highest amongst patients who are between 25 to 54 years of age. increased amounts and found in non-Hispanic white populations, so Alaska Natives, American Indian. I do practice up in Alaska, so when I get a break from the school, I go up to Alaska and I practice in Anchorage. And every time I'm up there, a lot of commercials are dealing with the opioid epidemic up there. Those communities are much more susceptible to it. Again, smaller communities, lots of poverty, can increase chances of patients developing an opioid addiction. And we see an awful lot of it in the Alaska Native population. Men were more likely to die from an overdose, but mortality gap is definitely changing between men and women. Some patient populations are much more likely to abuse opioid prescriptions. So obtaining overlapping prescriptions from multiple providers and pharmacies. That's why we have the drug monitoring programs, is to be able to monitor for that. So if you are going to prescribe an opioid, you're supposed to be logging into the drug monitoring program, put their name into that program, find out if they've received any medications or any prescription opioids in the last time period. They're also looking for your Schedule 4 medications, such as your benzodiazepines, which again, in combination with an opioid, could be devastating. Taking higher than normal dosages of pain relievers, having some form of mental illness or history of alcohol or other substance use, and then living in rural areas and having low income were also found to be risk factors. Big concern again, as we mentioned earlier, is benzodiazepines or anything sedative for medications. Combination of those two is particularly devastating for patients because of the fact that once they go unconscious, then they stop breathing. I had surgery just over 6 years ago now, and when I woke up from surgery, my rate of my pain is being attacked by ninjas. So I was hooked up to an IV and I was given morphine. Well, morphine absolutely changed stopped my pain because it stopped my breathing. When I wasn't breathing, I wasn't really in much pain anymore. And so then all the alarms went off and people came and woke me up. And at that point, I could remember to breathe. But as soon as I went unconscious again, I stopped breathing. And so I had a friend in there with me in the recovery, and he basically sat there and pinched me for like 2 hours. And I kept going, "Why are you pinching me? I don't understand why you're pinching me." He's going, "Because I'm trying to keep you awake. Because once you're awake, everything's fine. But as soon as you go unconscious, all the alarms go off." So anything that's a sedative medication, that's why patients who are taking opioids really need to avoid any other kind of depressant medications that potentially can make them go to sleep. Because once that happens, the breathing centers shut down and patients just stop breathing. So benzodiazepines examples are things like Valium, Xanax, Ativan. Any of those medications increase the chance that the opioids can potentially kill the patient. So which of the following is not a typical sign of a patient experiencing an opioid overdose? And the correct answer is the dilated pupils. They have pinpoint pupils. So you want to remember the mnemonic blue. So B is breathing. So breathing on patients who on opioids tend to be kind of shallow, potentially erratic, until potentially it can be completely absent. Lips tend to be blue because of poor circulation. They start to become cyanotic. U is unresponsive, so it could get to the point where patients are not really responding to verbal or physical stimulation. And then the eyes have pinpoint pupils. And this is very different than a lot of other drugs, which result in a dilated pupil. These patients end up having pinpoint pupils. So remember the mnemonic blue. B is breathing, lips are blue, unresponsive, and their eyes are pinpoint pupils. So what treatment should be administered for someone who's experiencing an opioid overdose? And the correct answer is C, is naloxone. Naloxone now is over the counter, And I think that's been really important. I'm going to show you some stats recently that have shown that some of the opioid epidemic has been dropping, that the amount of opioid overdoses has been decreasing. And a thought is because naloxone is more readily available. And patients who are potentially abusing opioids are actually carrying naloxone in order to just in case they do overdose. So naloxone is the most common. You can get it over the counter, and I would recommend that you have an emergency kit in your office. I think all of us should have an emergency kit. In that emergency kit should be, your things like your acetazolamide, so Diamox for your angle closures, should be, a fourth generation fluoroquinolone for patients who come with an ulcer, should be bags of Ringer's IV solution for chemical burns. And in that kit should be your naloxone. And so if you want, send me an email. I'm happy to share with you what we kind of have commonly in our emergency kit. It's not necessarily all inclusive, but I think it'll give you a kind of a good start for it. So if you want, just email me. I'm happy to send that to you. And in that kit, I do think that you should have your naloxone. Just in case patients do come in with an opioid overdose, that you have that available for them. So with naloxone, the most useful would be either to do IV or IM. That's not something you're going to be able to do. So you're going to end up doing the inhaler component to it. So for anything that's associated with life-threatening emergency, naloxone intranasally is recommended, and there may be repeat doses needed to be given. When you get naloxone, it typically comes with 2 units in it. I probably would recommend buying 2 boxes of it so that you have potentially 4 available because you may need more than 2 of them. The little injector looks like this. So you shove it up their nostril, you give the 4 milligrams up that nostril, you wait about a minute or so. If they're not responding, you do another one to the next nostril, and you continue alternating that until they become basically conscious or that your EMT people show up. When I was in Portland, my office was kind of part of the clinic. So people had to kind of walk by me to get to the back of the clinic. And I had one of the attendings come by and say, do you know where the AED is? And that's kind of a casual statement to make for asking for where the defibrillator is. And I'm going, yeah, I can show you where it is. I'm just a little concerned that you're casually just asking me where the defibrillator is. And I said, what's going on? And she said, well, we have a patient she's just kind of not responding very well. We just think that she's having some sugar levels because she's got diabetes. And I went, okay, so let's go take a look at her. And I went to the room where they were taking fundus camera pictures of her, and she basically had passed out at that point. And her boyfriend's kind of sitting there holding her in this chair, and she's probably about 200 pounds, and she was like a bag of jelly. And it literally took him to kind of just hold her in the chair. And that room wasn't great access into that room to move people around. So when the EMT people walked in, they were like Greek gods walking in, like 6'4" and just all muscles. And it took 3 of them to move her out of the room. So when we see those TV shows where people move people from a gurney over and they move them really easily, these people are like a bag of jelly. And it's challenging to have people that are unconscious. In particular, trying to move them and get them into a position where they're not potentially going to hurt themselves even more from that. When we talk about people who are unconscious getting naloxone, there's a concern that patients come out of that unconsciousness and they come out swinging. And I don't know how much validity there really is in it. I'm not an EMT, so I can't really tell you from firsthand experience, but I've done some research into the area. And the thought is that the original thought they come out swinging is because you broke their high. What some of the research indicates is really that when patients are unconscious and they're coming out into an environment that's very agitated, that people are kind of running around and doing stuff, is that they come out kind of in a fight response because they've assumed that all this agitation is potentially going to harm them. So they come out swinging because the environment around them is agitated. So the thought is that the best that you can is to make sure that you're trying to keep the environment as calm as possible so that when people come out of it, they're not coming out into an agitated environment and want to basically fight for it. It's quite possible that they are coming out of their high and they are going to be angry about that. So, take precautions to make sure that you're not going to get hit. But ultimately, the thought is try to keep the environment as calm as possible so when people come out of it, they're not coming into a really agitated and they feel that they are in danger. There have been a couple other products that have been approved. So naloxone went over the counter. There's another medication called Opvee that's now available for patients. It's still a prescription product, but is also available for patients for opioid overdoses. So this is the data I was showing you. So in October 24, the CDC came out with a report saying that they've seen a drop in deaths from fentanyl. And there was a kind of a big drop in the early beginning, the late part of 2024, early 2025. And so fatal overdoses are down about 13%. This is a significant improvement from the month before, where there was only a 10% drop of fatalities. But up to that point, it's been a steady rise. So from 2017, even earlier than that, there's just been steady rise in people dying. In particular, increased deaths happening from fentanyl. Fentanyl is a very powerful drug. It basically takes a couple grains of it to potentially kill a person, and that's unfortunately where a lot of drugs are laced with is fentanyl. In particularly drugs from Mexico, etc. I was on a cruise somewhere and I stopped by a pharmacy, and one of the physicians there was saying, be really careful about taking any medications like oxycodone or hydrocodone that are made in Mexico or from other that are not kind of like brand name products. And he said it's even hard to tell on brand name products because the drug cartels have made the drugs look exactly like brand name drugs. So sometimes it's hard to tell. And he said a lot of them sometimes are actually laced with fentanyl. So fentanyl has been one of the reasons why there's been a dramatic increase in deaths. But the thoughts behind why there's been this reduction is that potentially it's been secondary to getting a lot of that fentanyl off the streets. So that was kind of the dramatic increase in being able to try to pull some of that fentanyl off the streets has certainly decreased that amount. They did find that in the Black and Native American populations that the drop in deaths hasn't really shown up in that population yet, hoping that it will. And one of the reasons they thought is that it's an expansion of naloxone, and medications for opioid use disorder have certainly improved survival rates in patients. And one survey in Seattle found that 85% of high risk drug users now carry the overdose reversal medication, so they carry naloxone on them. So if something happens, then it's readily available for them. So I think the fact that naloxone went over the counter is now much more available, and people who are abusing drugs are becoming very aware of the fact that they could die from this, and carrying naloxone has certainly shown a decreasing trend for overdose deaths. All right, so let's talk about ocular pain. Probably not the funnest picture to see. Well, morning here for me, but probably afternoon for a lot of you. So you have a patient who presents with a corneal abrasion. So you can see the picture on the right there, corneal abrasion. They report their pain is about 6 out of 10. How would you manage this patient's pain? All right, so a majority going here. My little bar is coming up here is making me hard to see what all these answers are here. I think it's alternating ibuprofen and acetaminophen. No, bandaged contact lens, and then alternating acetaminophen and ibuprofen. I think a bandaged contact lens would work great in this case. I think it's going to help manage the pain. It's also going to help healing of the wounds and they're blinking over top of it. And I would probably go with the alternation of Tylenol and ibuprofen. In that 6 out of 10 range, both acetaminophen and ibuprofen can likely manage that pain. And by alternating them every 2 hours, what you're getting is 2 different ways of pain relief in still a time period where they're not potentially going to get toxicity, right? So most of these medications are on every 4 to 6 hour time schedule. So if you're alternating them every 2 hours, they're still getting medications every 4 hours. With respect to acetaminophen every 4 hours and ibuprofen every 4 hours, they're just alternating them every 2 hours. I think topical NSAIDs could be an option for this patient as well. You might want to put a steroid on there just to help the healing response. I don't think we necessarily need to go into hydrocodone or Tylenol 3, but again, depends on really that patient's presentation and how bad they really feel that pain is. So in the inflammatory cascade, we know that steroids are our gold standard for stopping inflammation. They intervene at a higher spot than, say, NSAIDs do. So on this graph here, or this flow chart here, you can see that in that phospholipase A area, that's where steroids intervene. So they block both pathways. They block both the lipo pathway as well as the cyclo pathway. When we talk about NSAIDs, NSAIDs only sorry, I can't speak this morning, only block the cyclo pathway. And so if we're talking about shutting down inflammation, steroids are going to be far better than NSAIDs in reducing inflammation. So again, NSAIDs only block the cyclo pathway. That leaves the lipo pathway still involved in inflammation. So unlike steroids, NSAIDs only have one mechanism for decreasing inflammation, which is why if we want the gold standard to shut down inflammation, really your steroids are your best option. NSAIDs do have the ability to reduce inflammation systemically. Topically, they're less effective, right? So we find that for systemic NSAIDs, they have a really good ability to reduce inflammation. They can still do it topical wise. They're just not, say, as good as, certainly not good as steroids, and they are not as effective as they would have been taken systemically. They are still quite potent, and they also lack the side effects of the steroids. So for reducing inflammation, if you're talking a uveitis, then your NSAIDs aren't going to play a role for that. But if you're talking, say, post-operatively, then NSAIDs, I think, are a great way to help reduce inflammation, and they're also helping managing pain at that point as well. So there are other properties to NSAIDs that make them really useful in optometry. The big one is the pain management wise for them. They also for patients systemic wise can help for people who aren't feeling well, can help reduce fever. They have antipyretic effects for them. But I think when we tend to think about NSAIDs, we tend to think about them around things like cataract surgery to help both reduce pain as well as reduce inflammation. So with analgesic medications, there's really kind of three pathways that are involved in pain relief. The peripherally acting ones, these act on peripheral pain receptors, and that's really where your NSAIDs kick in. Anesthetic agents, these basically block the conduction pathway. So they basically shut down your action potentials for the nerves that can carry pain. And that's where things like proparacaine will kick in. And then your centrally acting agents, these ones have an ability to kind of shut down those pathways in the central nervous system. And that's where your narcotics kick in. Thought potentially where acetaminophen kicks in as well. The important part of the centrally acting ones is you see that they interrupt the pain message and its emotional responses. So when we talk about comparison of pain management, if you're comparing things like acetaminophen and ibuprofen to things like your opioids, yeah, remember your NSAIDs are taking more that peripheral pain, but they don't have this emotional component to it. Like your central acting ones do, like your narcotics. And so when you compare pain management, you can say, yep, they both can take care of patients' pain at 6 out of 10, but a patient's always going to prefer an opioid because there's this emotional response that goes along with it. It's kind of really powerful just not to care about the pain anymore. And that's very different than not being in pain. So when we talk about equivalent pain management systems for patients, you're going to remember that patients are always going to prefer an opioid because of the fact that it is that emotional component saying, I just don't care about pain anymore. Yeah, I don't feel the pain equally, but the other one is I also just don't care about it. So let's talk about topical NSAIDs. So which of the following is an off-label use that topical NSAIDs have been used to treat? And the off-label use in this case is CME. So the approved uses for your topical NSAIDs include postoperative pain. That's where most of them are approved for. Inhibition of intraocular miosis and ocular itching. Things like Acular and so on are actually indicated for itching. It's not something we typically commonly ever use. We have much better medications to help reduce itching in patients, but it is actually an approved use. The off-label use is for CME. And it's an important consideration for patients postoperatively, increasing chance for development of CME, in particular patients who have diabetes. Diabetes is a perfusion disorder, dramatically increases the chance that patients can develop postoperatively CME. So most surgeons would actually indicate the patients start with a topical NSAID prior to surgery and then concurrently through their post-op period, basically treating them like they already have CME. So the role of NSAIDs in eye care, commonly used in the treatment of postoperative inflammation following cataract surgery and other various surgical procedures, helps to reduce not only inflammation, but also helps to reduce pain in patients. As I had mentioned, in patients who have diabetes, that a lot of times topical NSAIDs are used prior to the surgery as well as postoperatively as well. Often NSAIDs are combined with steroids to treat CME. One of the very first ones was Acular, 0.5%. It's available as a generic now. It is indicated for ocular itching in patients who have seasonal allergic conjunctivitis, also indicated for postoperative inflammation after cataract surgery. It is QID dosing, and the major downside to this one is this high level of stinging on installation. And you can see that the corneal effects may cause keratitis. Continued use may cause severe corneal adverse effects, including corneal thinning, erosion, perforation, and ulceration. When we talk about these corneal melt syndromes that have happened with NSAIDs, they're really with our first generation ones. The newer ones, it's much less likely we're going to ever see a corneal melt with, Prolensa or Alevro. It's really these original ones, mainly ketorolac was, and diclofenac is part of that as well. It's really the original ones. But I do think you still have to be a little bit cautious about patients who have sick corneas. So if they have things like Fuchs or other corneal degenerations or dystrophies, you might be wanting to be a bit cautious on using an NSAID, particularly for any long-term use. Acular LS, this is 0.4%, equal efficacy to Acular without the sting. It was particularly one of the most widely prescribed topical NSAIDs for a long period of time. It's still QID dosing, so that's kind of limits its use, particularly now that we have ones that are once a day. Acuvale is ketorolac. This was a preservative-free medication, so great for patients post-operatively cataract surgery, not putting any other preservatives into the mix. The downside is just a really pretty expensive medication because it's preservative-free. This is one of the medications that first now moved into BID dosing for patients. Because of the carboxymellocellulose, it did increase contact time on the ocular surface, so it allowed us to decrease the dosing to twice a day versus 4 times a day. Diclofenac or Voltaren, this again, one of the original ones that's out there for postoperative inflammation. Cataract surgery was 1 drop QID beginning 24 hours before surgery and then continuing for 2 weeks after. It was also indicated for corneal refractive surgery, and some thought that Voltaren had the ability to prevent like binding of bugs and stuff to contact lenses. So after doing, say, like PRK, you'd put a bandaged contact lens on it. It's thought that the use of this NSAID could decrease the chance that, bugs are binding to the contact lens to decrease postoperative infections. Not sure that's really a mindset that most surgeons are thinking about at this point in time, but there was some thought that that was a benefit. There is major stinging with this one as well. Bromfenac, this one has bromsite in it, which is Duracite. And Duracite is what we find in azicite. It's also what we find in, I'm forgetting the name right now, antibiotic. Anyway, it increases contact time. Basically, it comes as a drop, but it forms a gel coat on the front surface of the eye, increasing the amount of contact time that's there. This was twice daily, starting the day before surgery and 2 weeks after. It is approved for ocular pain as well as inflammation post-op cataract surgery. Prolensa, this is now one of medications we got into once a day dosing. Again, indicated for post-operative inflammation and reduction of ocular pain. Dipafenac, the original one was Nevanac. This was TID dosing. It was at 0.1%. When they increased the concentration to 0.3% as the Levro, it now drops down to once a day dosing. Again, 1 day prior to surgery, continued on the day of surgery and through the first 2 weeks of postoperative period. This is a suspension that must be shaken. I agree with Dr. Onifree that we're talking about, medications in putting on a prescription, make sure that they shake the medication because it's in suspension. I always just remember shake your acetate. So things like Pred Forte needs to be shaken. So our major side effects to topical NSAIDs. Must use extreme caution with patients who have epithelial compromise. So again, any condition that's resulting in compromise to the cornea can result in increased issues with these medications because they just decrease healing response. The incidence for NSAID-related complications is low. It was most commonly seen with generic diclofenac, but I think in any sick corneas, you're going to have to just be cautious of it. The major or the sort of minor side effects that can happen when taking an NSAID typically is the burning and stinging that's involved with it. It can increase the chance of developing PEE or SPK. Again, avoiding in patients who have sick corneas, particularly any things that have degenerations, Fuchs, etc., in particular using long-term wise these drugs. I would say most commonly we tend to think about these medications evolving around cataract surgery, not only for the postoperative pain and inflammation, but also in the treatment or prevention of development of CME in patients. With cataract surgery, it releases prostaglandins, which are an inflammatory mediator, gets to the posterior pole, results in changes in that permeability of the tissue, which increases the amount of fluid that potentially can be there. Topical NSAIDs are considered first-line treatment for these patients in addition to steroids. If it goes beyond that, then we start talking about oral steroids, oral medications, but most patients are easily to be managed on topical NSAIDs and steroids. Remember that CME typically presents in that 4 to 6 week time period. So you've done your 1 month post-op on them, given them their final prescription, they get their glasses, and they come back a few days later saying, yep, these don't work for me anymore. Typical onset for CME is generally in the 4 to 6 week time period. Remember, with your patients with diabetes, they're much more likely to develop postoperative CME. So all of the surgeons I work with all prescribe topical NSAIDs prior to the surgery. And basically for that month post-op wise, basically they're treating them like they already have developed CME. So what role does cycloplegia, such as homatropine, play in the treatment of uveitis? Now, unfortunately, we can't get homatropine anymore, which is unfortunate because it's almost a perfect cycloplegic agent. But when we're thinking about cycloplegia and treating a patient with uveitis, why are we giving them a cycloplegic agent? All right, let's see what you said. So really the correct answer is all the above, all three. Now, I know that most people chose 1 and 2, and that was mainly because what we were taught in optometry school is it helps to reduce pain or discomfort, takes the ciliary body out of spasm, which it does. It helps to reduce the synechial formation, and I usually say reduce synechial formation and not necessarily snap synechia. When you think about your cycloplegic agents, they're effectively passive dilators. What they're doing is preventing the pupil from constricting down. We use phenylephrine to activate the dilators. So if you want to snap synechia, you're going to be far better off putting in phenylephrine than you are to put any cycloplegic agent in. I'm not saying you don't do both, but phenylephrine is really going to activate the dilators and pull the iris open to snap synechia. So that's why we have 10% phenyl. 10% phenyl has been designed to really snap synechia. Now, remember, no one's died from 2.5% phenyl, but they have died from 10. Be really cautious in patients who've got blood pressure issues, particularly younger patients as well, with giving them 10% phenyl because it can cause problems. But to snap synechia, really, we're using phenylephrine. The cycloplegic agents is basically pulling the iris away from the lens, and so there's less chance for adhesion at that point. But the cycloplegics also help to reduce inflammation. Now, there's some debate on whether or not it's going to help say cyclopentolate is going to do it, but we know homatropine, scopolamine, and atropine do actually help to stabilize the blood vessels on the iris and makes them less leaky. So it actually has an anti-inflammatory component to it. And that's really important for us to remember because when we're treating a patient with uveitis, the first drug that they want to come off is the cycloplegic agent because they're dilated. However, I would recommend at that point you don't taper your steroid because you're taking two means of reducing inflammation away at the same time. At that point, you can have a rebound or a flare-up. So when you're removing the cycloplegic agent, my recommendation is keep the steroid in the same dosing for at least for the next few days, and then start considering tapering your steroid after that. Some debate again whether or not cyclopentolate does it. I'm not too sure that we have a good answer on that one, but we do know that things like homatropine, scopolamine, and atropine, it does help to stabilize the blood vessels on the iris and helps make them less leaky. And that actually can be important for patients who, say, have HSV keratitis and they have an iritis. Well, we're not likely going to put a steroid on a patient with active HSV, but you could give them a cycloplegic agent, which can actually help reduce the inflammation. So the uses of cycloplegic agents relieves the pain of ciliary muscle spasm, prevents posterior synechia, so less iris contact with the anterior lens capsule, and decreases the permeability of inflamed vessels, which reduces cells and protein in the anterior chamber. The ones we typically think about as cycloplegics, tropicamide's not on here, so remember your cycloplegic agents, tropicamide, cyclopentolate, homatropine, scopolamine, and atropine. Tropicamide just doesn't have enough kick for us, so the minimum we would start with would be cyclopentolate. Unfortunately, now that we can't get homatropine or scopolamine. Homatropine really was the perfect cycloplegic agent for uveitis because it put them in a constant state of flux, right? Just we're constantly moving. Downside to atropine is, yeah, you can give one drop and they're dilated for a week. The downside is that you actually put them into an immobile state. You lock them into a dilated state, which at that point can develop synechia formation because they're basically not moving. So I'd say most of us are using cyclopentolate at this point in time, typically 1 to 2%, generally 2 to 3 times a day as well. So we have a patient who has a vitritis secondary to her sarcoid, and we consider that she has a vitritis. She has a mild vitritis. So there's several cells in the vitreous. What would be your initial oral prednisone dosing for this patient? All right, let's see what you said. And I would say the correct answer in this case would probably be 30. We typically, when we think about a mild vitritis, we're talking 20 to 40. In moderate, 40 to 60. In severe, usually greater than 60. So in this case, I'd probably consider the 30 milligrams would probably be the most appropriate. Remember, oral pred comes in 1, 2.5, 5, 10, 20, and 50 milligram tablets. Also comes in solution as well as a syrup. Treatment guidelines typically for a mild to moderate, things like vitritis, we talk about 20 to 40 milligrams, moderate to severe, 40 to 60. Anything severe, greater than 60, and increase if necessary. When we think about conditions like temporal arteritis, generally we're talking that 80 to 100 milligram dosing, generally start on an IV first and then brought onto orals after that. When we think about side effects of oral steroids, there is a steroid receptor in every cell in your body. So the potential for reactions to steroids is really high because it affects almost every system in your body. Let's talk about that first, and we'll go back to the medral dose pack. So side effects, so things like change in body distribution of fat, there's increased hair production, changes in blood pressure, changes in blood sugar levels. I find this one in the middle here, the euphoria depression one, the emotional disturbances one, interesting. So we typically think about patients, particularly on lower doses of oral steroids, to become really kind of bitchy and irritable. They become not very nice people. However, when you go into higher doses, it kicks into euphoric state. And I didn't know this until I had a patient up in Alaska, a young girl, 13 years of age, came in. her mom brought her in on an emergency basis on a Monday afternoon. She was reading on Saturday night, reading a book, and all of a sudden she got this kind of really pounding headache right above her left eye, and then her vision went blurry. So she came in, she was 20/30 in both eyes. I refracted her and she was like, give her 3 clicks of minus and she's 20/15 in the right eye. But no matter what I did refraction wise in the left eye, nothing got better. So we took OCTs of her and she had basically all these little cyst-like appearances right across her fundus. So almost like little central cirrhosis all the way across the fundus. And I'm looking at that going, huh, that looks like a chorioretinitis. VKH comes to mind in this case, and it is much more prevalent in Alaska. I've seen 3 cases of VKH, and they all were in Alaska. But when I looked at the young girl, she appeared Caucasian or white, and her mom was white, but her father was actually an Inuit, so a native Alaskan. And so I didn't really want to tell the young girl that she had VKH because I was afraid she was going to Google it and find out that there's a variant of VKH that she could die from. So I kind of separated the mom and the daughter. I just told one of the techs to take her and run another OCT. And then I just kind of said to the mom, I said, I think it's this condition, but I don't know for sure. Can I tell your daughter? What should I tell your daughter? And she goes, absolutely don't tell her because she will absolutely Google it. Just tell her you're making a referral. And then, we'll go see the retinal specialist the next day. So the next day they go see retina, and the mom actually called me that night to say, you seem really concerned about my daughter. And so I wanted to update you on what's going on. And I'm going, that was really nice of you. I don't usually have patients calling me to make sure that I'm okay. And that was very sweet of you to call. And they did confirm that she had VKH, and they put her on 60 milligrams of oral steroid. She's probably 80 pounds soaking wet. So a massive dose of steroid. I ran into the mom the following week because she came in for her eye exam at that point, and I said, how's your daughter doing? She goes, oh, much better. Her vision's getting better. They're thinking about, kind of tapering the steroid a bit down. And I said, so has there been any side effects to the steroid? And she goes, well, like what? And I'm going, well, people on steroids can become really kind of bitchy and irritable. And she goes, first of all, my daughter's 13. I went, okay. And she said, no, she was lying on the ground laughing hysterically for 2 days. High dose steroids kicks you into a euphoric state. She said it was just the weirdest thing. Like she was on it. She's literally like on the ground laughing hysterically. So remember, high doses kicks you into a euphoric state. Let's go back to the Medrol dose pack. I really don't prescribe oral pred. Anytime I've done any type of treatment for uveitis, it's been a Medrol dose pack. Why? Because methylpred is actually a bit more powerful than prednisone, and it's already got a built-in taper to it. And you can see in this packaging here, it tells them exactly when they're supposed to take the drugs, even this little kind of description down below. It doesn't matter what time of the day you actually get the prescription. You're supposed to take the 6 pills on that first day. The next is 5, 4, 3, 2, and 1. So it's already got a built-in taper. Really kind of perfect, I think, for optometry and when we're treating things like uveitis, particularly vitritis, that for us, this is actually a really good way to go because of the fact that it has actually a built-in taper to it. All right, so patients suffering from, this is a patient I had during my residency. I was on call. I was rocking the pager back then, so I got paged and called the patient. It was like 7:30 in the morning. And she said, well, I rolled my curling iron onto the front part of my eye. So missed her lids, everything, and rolled it right onto the front part of her cornea. I said, oh, it must hurt. And she goes, yeah. And I said, rank your pain. She said, about 8 out of 10. And I said, okay, so you're on your way in, right? And she goes, oh, no, I got to work today. I'll see you about 4:30. And I'm going, yeah, you're not going to make it until 4:30. So by like 9 o'clock, she was in the office because she couldn't stand the pain anymore. So what are we going to recommend for her for pain management? I know there's a lot of choices here, so I'll give you a second to go through them. All right, let's see what you said. No one chose enucleation. I'm a little disappointed about that. Also, no one chose giving a bottle of Percaine, but who does choose that? Yep, urgent care and emergency rooms do. And before I go through the rest of the answers, let me kind of address that issue. The reason that they do it is because of this article. So topical tetracaine given every hour is found to be safe and really highly effective for patients who have uncomplicated corneal abrasions, double-blind randomized clinical trial. Sounds really great study, right? We love double-blind randomized trials. This is in the Academic Emergency Medicine Journal. The downside is that the physicians don't actually read it. They don't read the article. It's actually a compounded product of tetracaine. It's not what you buy in a bottle. It's not what we have in our offices. It's actually a compounded, non-preserved formulation of tetracaine. In addition to that, the study's been refuted. And they actually found when they did more analysis in the study that patients, yeah, they didn't have any pain, but they actually were increased chance of developing corneal ulcers from it. So we know giving topical anesthetics on a patient is going to result in disruption to their epithelium, and eventually they're going to lose their epithelium. So urgent care still does this. When I was in Alaska this past summer, we actually took 2 bottles of tetracaine away from patients who were given to them in the urgent care. So please educate your urgent care people that this is not a good practice for them to do. If you want, again, send me an email. I'm happy to send you this article. I'm happy to send you the refuted article, and I'm happy to just send you 30 articles that can tell you that you're going to lose the epithelium. However, this is still out there. And so ultimately, I think that's who tends to use these are urgent care and emergency rooms. All right, let's go back to your answers here. And in this case, the majority chose acetaminophen with ibuprofen. We've got some going to Tylenol 3, and then some doing acetaminophen 1,000 milligrams plus 400 ibuprofen. Now, I would probably go with answer D, 1,000 milligrams plus 400 milligrams of ibuprofen given at one time. This is equivalent to 5 milligrams of hydrocodone. So when you're talking 8 out of 10 pain, that's what I woke up with when after my surgery, 8 out of 10. So acetaminophen and ibuprofen weren't likely going to take care of that. Opioids would, which I end up getting morphine and stop breathing. But ultimately, that 8 out of 10 is a really kind of a tough cutoff because I'm not too sure acetaminophen and ibuprofen will take care of it. And I don't know if I want to go into an opioid. So I think a good alternative in this case is I don't think the acetaminophen ibuprofen alternating 2x325s and 2x200s is going to get you over that threshold of 8 out of 10 pain. Because you have to remember individually, those medications are probably good in the 5 to 6 range. When you talk 1,000 milligrams of acetaminophen plus 400 milligrams of ibuprofen given at one time, you're now getting up to equivalent of 5 milligrams of hydrocodone. So this is what emergency rooms are now kind of defaulting to, as opposed to going into an opioid, is they're defaulting to this. We end up giving this patient Tylenol 3. I don't know if I'm a big fan of Tylenol 3. I'm a big fan of codeine. Hi, my name's Blair. I love codeine because codeine works really, really well for me. And the upside to codeine is it kicks in really quickly. Kicks in within about 20 minutes. I started getting pain relief. We gave this patient Tylenol 3, but I think no, this was back during my residency, so I don't think we really knew that 1,000 milligrams of acetaminophen and ibuprofen would work. I think now I'd probably go with the acetaminophen and ibuprofen. But I do think Tylenol 3 is potentially an option for you as well. I'm just not too sure topical NSAIDs or topical steroids are going to be enough to take care of that pain. The patient's going to need a topical steroid because there's lots of inflammation with thermal burns. But we also needed to debride the blister that was there too. She came in, there was a huge blister there. We had to debride that off, put the patient on a bandaged contact lens, and we gave her Tylenol 3. All right, let's talk about oral pain management. So reasons why we'd want to be able to prescribe oral analgesics for things like corneal ulcers, herpes simplex zoster, post-surgical trauma, thermal burns, and periorbital infections like dacryocystitis and preseptals. When I was putting together this presentation, I've done some lecturing with a corneal specialist, Dr. Greenwood out of Fargo, North Dakota. And I said, so what do you use for pain management? And I was expecting him to tell me that he uses Tylenol 3 or hydrocodone or et cetera. And he doesn't use any opioids. He says, I'm not going to contribute to the opioid epidemic. I can manage these patients on doing like the 1,000 milligrams of acetaminophen and ibuprofen. And I thought that was really interesting. That the person I think that would probably most likely use oral analgesics didn't use them. So, or didn't use the opioids anyway. So I do think that we have ways around that, but I'm glad we still have the ability to prescribe it because I do think there are patients where we just need to go to, a Tylenol with codeine or potentially hydrocodone or oxycodone. With patients who are in pain, they do not like to be in pain. right? So patients who are in pain want their pain managed at that point in time, and they want it over a 24-hour time schedule as well. So they don't want to be pain-free for 16 hours and then pain for 8. We generally like to know what's causing the pain before we prescribe for it. So kind of like almost anything, we don't like to prescribe unless we know what is causing the pain. Non-prescription drugs should be first choice and tend to be lower cost and more available for patients. Treating patients by the simplest and safest means to alleviate pain. So again, doing things like bandaged contact lenses, doing ibuprofen, acetaminophen, that type of stuff, cycloplegic agents, usually kind of the better ways to do it before we start getting into prescription drugs. Mild to moderate pain, often successfully managed by using acetaminophen or NSAIDs. Your moderate to severe pain, often best treated with an opioid because of the fact it gets over that pain threshold. So after my surgery, I was given 1 oxycodone that evening. And then at that point, I started alternating ibuprofen and acetaminophen. And because I had gotten over that pain threshold, then acetaminophen and ibuprofen could prevent me from getting back up in pain. However, if I'd gone back up above that pain kind of threshold of 8, again, probably I'd need to use another opioid to get me back down below that. Now, it was interesting. How many oxycodone was I given after my surgery to take home with me? I was given 30 of them. I didn't use them. Now, my roommate really liked them. He thought they were quite a lot of fun. As I went looking for them, going, I probably should just throw these away or take them in. And they weren't there. So he said, oh, yeah, I finished those a long time ago. So I didn't take them. He did. Other adjunctive treatments, valuable for pain management, things like your cycloplegic agents. They be a little bit cautious about cycloplegic agents. Really, they're most effective in patients who have some form of iritis going on. A lot less successful for patients who have corneal abrasions, that type of stuff. So really, if there's an inflammatory component, then these are much better for them. So typically, if there is an iritis present, that's usually the best way to manage pain is, or best use for your cycloplegics to help manage that type of pain. Bandaged contact lenses, I think, are important. Topical skin creams for patients who have, an outbreak of zoster. NSAIDs, these are a drug of choice for treating mild to moderate ocular pain. They're also beneficial for systemic inflammation as well. They are readily absorbed from the GI tract. They are capable of crossing the blood-brain barrier as well. They exhibit what's called a ceiling effect. So there's a dosage beyond which no further analgesia occurs. So I'm actually teaching pharmacology at this point, and I was going through pharmacodynamics and pharmacokinetics, which is not fun for anybody. But remember your dose response curves. Most medications are what's called a first order kinetics. And first order means increasing amount of drug, increasing amount of activity, right? More enzyme is now being bound, more processing, and so more potential bioavailability of that drug. However, there's certain drugs that are what's called zero order kinetics. And your NSAIDs, acetaminophen, are in what's called zero order kinetics, which means that the dose that's given actually maximizes 100% activation of the receptors and the enzyme that's processing it. So at that point, with zero kinetics, the dosage that's given for that time period before the enzymes have ability to process that medication through, anything above that is just toxicity. So it's really important that we talk to patients who are taking acetaminophen and ibuprofen, that if they're taking kind of the maximum dose, that 4 hours later, that's the next time they can take that dose. If they take anything in between that, there's no additional benefit for them. So if they take it in 2 hours, they get no additional pain management from it. It's just toxicity at that point. And that's what ceiling effect is. There's just no additional benefit by giving any more of the drug. Now, what doesn't have a ceiling effect are things like hydrocodone and oxycodone. Because of tolerance issues, they don't ever reach a ceiling effect. So they can just keep taking more and more and have, downregulation, need more and more medication to get the same effect. So, but your things like acetaminophen and ibuprofen, really ensuring patients don't take additional medications in between the time periods because there's no additional benefit to them. There's variability that exists among the different NSAIDs, much like our prostaglandin analogs. If ibuprofen doesn't work, then try naproxen or try one of your prescription ones. I personally prefer naproxen, the little blue pills, versus the ibuprofen, little brown pills. Just certain medications work better for certain people. Aspirin, we really don't see this as used much as a pain reliever. It was mainly used as kind of an antiplatelet medication, so for patients who had kind of cardiovascular disease. But you've seen the dramatic decrease in patients coming in on aspirin, the 81 milligrams of aspirin, because in 2019, a couple big studies came out showing that aspirin should be used infrequently in the routine primary prevention of cardiovascular disease because of the lack of net benefit. Patients who are taking it just prophylactically, if they end up having a heart attack or a stroke, were much more likely to be hospitalized and more likely to die. There are patients who absolutely need to be on it. And if they're prescribed for it, then they absolutely need to be taking it. However, routine use for prophylactic dosing is just not indicated anymore. So for your patients, we used to have almost everybody over the age of 60 came in on 81 milligrams of aspirin. At this point in time, we're seeing a lot less of those patients. But there was also, when they released the results, they kind of released it in a way that scared a bunch of people. Scared a bunch of people who were taking 81 milligrams of aspirin and really should be taking it, they stopped. So if patients have any concerns that they're prescribed for it, then they should be taking it. Just routine use, they shouldn't be doing it. Ibuprofen, probably the most common one we tend to think about. In the United States, the maximum we can get over the counter is 200 milligrams. If you happen to be from Canada, you can get 400 and 600 over the counter. Typical dosing is 400 milligrams every 4 to 6 hours. Maximum daily dose over the counter is about 1,200 milligrams for pain. It's approved up to 3,200 milligrams if you're talking about treatment for osteoarthritis or rheumatoid arthritis. It reaches peak levels about 1 to 2 hours in. This is the most renally toxic of all the NSAIDs. So be cautious when you're getting up to 1,200 milligrams per day and you're doing it for more than a couple weeks. If patients have blood pressure issues, you're going to alter their blood pressure medications, in particular their diuretics. So be cautious in patients who have any renal disease, blood pressure issues, because it will long-term wise affect those, particularly when you start to get a maximum dosing. I prefer naproxen sodium, mainly because I think it just works better for me, but also its dosing is easier as well. It comes in 220 milligram tablets, so that's what your common Aleve is. The first dose is 2 pills on that first dose, and then the next one is 1 tablet every 8 to 12 hours after that. So versus the 4 to 6 you have from ibuprofen, it's basically every 8 to 10 hours after that. Indomethacin, this is a prescription NSAID, primarily used in patients who have a systemic inflammatory condition. We don't generally see this medication used for pain relief long-term wise because it has kind of the worst side effect profile. Patients really don't tolerate this medication long-term wise. Primarily, we'll see this used in patients who have, say, like a scleritis. It's used in the treatment for that. We just don't see it commonly used for long-term pain management. Typical dosings between 50 and 75 milligrams. So for like a scleritis, it would typically be 75 milligrams BID to TID. Ketoprofen. This one is indicated for patients who have mild to moderate pain, so menstrual cramps, swelling, pain associated with arthritis. This is a good alternative for those patients that you are really not tolerating indomethacin very well, that they could switch to ketoprofen. A lot less of the side effect profile to it, and it can be used to treat things like scleritis as well. Generally 25 to 50 milligrams every 6 to 8 hours is needed. Some people need to take as much as 75. Doses larger than 75 have been shown to really give no better pain relief, so really maxing out at 75. Ketorolac or Toradol. I put this in here because I had a wife of an emergency room physician saying, well, my husband does Toradol. Well, he does it because ultimately he's in an ER, and in lieu of opioids, they'll do Toradol, but it's an IV or IM pain management treatment. So almost all people are given an IV, and then after that, they're given the 10 milligrams of oral Toradol to take home after. But that's usually after they've been given an IV preparation of it. This is not something that I would say that we would ever prescribe for a patient. It's got very specific dosings. It has huge issues if they take too much. So I just threw it in here because someone had mentioned it, but it would not be something that I would say that we would ever prescribe. Your COX-2 inhibitors, you're likely seeing anybody who's got chronic pain, so osteoarthritis or rheumatoid arthritis, they're likely on Celebrex. This is a COX-2 inhibitor. So remember, we had the 2 pathways, lipo, cyclo, and within the cyclo pathway, there's actually 2 pathways there, COX-1 and COX-2. The COX-1 enzyme is really important in stabilizing the GI lining of our guts. So if you have a COX-1 inhibitor, it breaks down that lining, and then the gastric juices result in gastric or peptic ulcers. So to get around that, there's COX-2 inhibitors. And these block the COX-2 enzyme, keep the COX-1 enzyme intact, and so there's a lot less chance for GI upset, nausea, that type of stuff. Typical dosing for Celebrex is generally about 100 milligrams twice a day. There were a couple other products on the market, Vioxx and Bextra. They were removed because patients dying from cardiovascular complications. So COX-2 inhibitors get a pretty bad rap for cardiovascular complications, but all prescription NSAIDs have the same big black box warning on them. Just the COX-2s are just more indicated for the cardiovascular component. So if a 65-year-old patient suffers from osteoarthritis and is taking oral NSAIDs, so say indomethacin 50 milligrams daily for 10 years to help manage pain, which of the following is this patient also likely taking? So if they're taking a long-term NSAID, what are they also likely taking? Where is my baby? Oh, you can't see me. Sorry, because I have my background now, but Bennett just came to see me. And they're taking omeprazole or proton pump inhibitor. The proton pump inhibitors are the last step in producing the gastric juices in our gut. And so if you shut those down, they have a lot less chance of developing a peptic ulcer. So patients who are taking long-term NSAID use should be on a proton pump inhibitor. Remember, with your NSAIDs, chronic use can result in renal disease. So be very cautious in patients who have hypertension or congestive heart failure. Be careful about anybody who has an active peptic ulcer. Big black box warning on all your prescription NSAIDs for potential serious thrombotic events, so MIs and strokes. Proton pump inhibitors, again, indicated for patients on long-term use. So we see that with patients who come in on Celebrex. If they're on Celebrex, they're almost always on a proton pump inhibitor, so something like Losec or Prevacid. So which of the following is not a characteristic of acetaminophen? So when we tend to think about acetaminophen, which of these is not a typical characteristic of acetaminophen? Remember, acetaminophen, good for pain, good for fever, has no effect on inflammation. So it actually would be indicated for a patient with a high FEMA. You wouldn't want to give a patient with high FEMA an NSAID because it increased the amount of bleeding. So it's good for pain, good for fever, no effect on inflammation. We think that these work via the central nervous system issues. It is one of the more commonly used analgesics for mild to moderate pain. Again, take home, good for pain, good for fever, no effect on inflammation. Available as a tablet, capsule, syrup, oral solution, or suspension, even available as rectal suppositories. Adverse effects have been skin rashes, so a hypersensitivity reaction, nephrotoxicity, hematological things like anemia, and metabolic and electrolyte disturbances. Regular strength Tylenol is 325. Your extra strength is 500. There is an extended release formulation, which is 650. Original dosing, max dosing in a day for acetaminophen was 4 grams. It's now thought to be closer down to 3 grams. The most common cause for chronic liver toxicity or liver damage is acetaminophen overdosing. There's literally 50 different products that have acetaminophen in it. The FDA, when they in 2014 revised their rules for any prescription product that has acetaminophen in it. So if you're getting Tylenol with Tylenol 3 that's got acetaminophen in it, the maximum that can be in that pill is 325 milligrams. So effectively a regular strength Tylenol. Why? Because they realized that patients were taking other products that had acetaminophen in it and would get close to those toxicity doses. So now for patients, the recommendation for dosing is no more than 3 grams per day. It exhibits a ceiling effect like your NSAIDs and aspirin. So acetaminophen overdosing is the leading cause of liver failure in the US. Remember, there's multiple products that have acetaminophen in it. So their patients are probably taking these not even for the acetaminophen component. So Tylenol PM, they're taking it for the diphenylhydramine to help them go to sleep, but it's got acetaminophen in it. Midol Complete, NyQuil also has acetaminophen in it. The alternation of acetaminophen with ibuprofen. Why we do it on a 2-hour schedule? They could take them all at one time. They could take all the pills at one time, but then they're waiting 4 hours for the next time they can take pills. In addition to that, then we're getting to the end of their pain relief on those medications. So if they're alternating them every 2 hours, they never really get back into pain because they have another mechanism in play. Just make sure we're telling the patients that they're not extra dosing it. So 2 by 325s of acetaminophen followed by 2 hours later, 2 by 200 ibuprofen. Shouldn't be exceeding probably 3 to 3.2 grams of acetaminophen. Remember, ibuprofen over the counter, 1,200 milligrams is probably the maximum dose that they should be on. Gabapentin. This is an interesting medication. Gabapentin is really an anticonvulsive drug using for people who have seizures and so on, but it is indicated for patients who have particularly chronic neuropathic pain. So postherpetic neuralgia, diabetic neuropathy, it's extremely good for managing that type of pain as well. What it's not really good at is managing acute severe pain. So patient who has a corneal abrasion or recurrent corneal erosion, it's probably not really going to manage that pain very well. Emergency rooms have really moved to gabapentin to try to get away from the opioids, but for that type of pain management, that acute pain, it's not necessarily a really good medication to do that. So I think for us, it'd be good for, like, say, a patient with, herpes zoster, keratitis, but for kind of other acute pains, I'm not too sure it's a great medication for. It comes in 100 and 300 milligram capsules. Really, we only use the 300 milligrams, but this is a tighter up medication. In other words, you don't start with a full 1,800 milligrams. You start with 300 one day, then it's 600 and 900, and then you tighter your way up to 1,800 milligrams. This is a medication that has a strong sedative effect to it. So the first time they're taking it really should be taken at nighttime. It will make them dopey. So making sure that they're not going to be, driving a truck right after that. This is a couple studies they indicated earlier that 1,000 milligrams of acetaminophen plus 400 milligrams of ibuprofen was equivalent to 5 milligrams of hydrocodone. Now that is strictly on pain scale, right? So they reduce pain in the same degree. However, remember that emotional component that goes along with your hydrocodone, that patients are always going to prefer hydrocodone over acetaminophen and ibuprofen because it just makes them not care about the pain. But when we're talking strictly pain management wise, this is what I would go for patients. My roommate who has had his Achilles tendon have to be replaced and in pain, he basically said nothing worked for him. I said, well, try this. Try 1,000 milligrams of acetaminophen and ibuprofen. He goes, it's not going to work for me. And it did. So to me, I think this is a great way for that kind of, severe pain. And then at that point, they can start going into the alternation, but it's 4 hours later because they're taking both of these at the same time. Then they can do the 2 by 325s, then 2 by 200s and alternating those every 2 hours. Opioids, drug of choice for severe acute pain. CNS side effects, dizziness, lightheadedness, sedation, and drowsiness are the most common. The mood elevation, euphoria, and disorientation can occur in some patients, and it's typically when they're starting doing it via IV preparations. Usually swallowing pills doesn't give them that euphoric effect, mainly if they're snorting it or injecting it. Constipation, long-term wise, they need something colace in order to help reduce the constipation. The major side effect is the respiratory depression. Most serious side effect of the opioids, it basically shuts down their breathing centers. Avoid all depressants, especially using with alcohol, again, because you don't want them to kind of go to sleep and stop breathing. There's all your different scheduled medications. So remember, with your scheduled medications, you need a DA number in order to prescribe them. And our scheduled medications are telling us the potential for addiction issues. Schedule 5s have a very low chance for addiction. That would include medications like cough medicine that has codeine in it, up to Schedule 1s, which there's really no commercially available product. But your Schedule 2s are the ones we get most concerned about. Oxycodone, hydrocodone, meparidine's in there as well, hydromorphone's in there. Schedule 4 is tramadol. It's a synthetic analog of codeine, so thought to be less chance for addiction on that one. Codeine with acetaminophen is a Schedule 3 medication. Codeine in and of itself is actually a Schedule 2 medication. Most states that allow you to prescribe hydrocodone and oxycodone, you're being grandfathered in because it used to be Schedule 3s. Doesn't mean you can actually prescribe all Schedule 2s. Codeine, I really do like codeine because it kicks in very quickly, kicks in within 20 minutes of ingestion, peaks about 1 to 2 hours in. I put up the top, Tylenol 3 and 4 no longer available as a brand name, but we tend to refer to them that just because it's what's most familiar with us. Tylenol 3s are going to be what's you're most likely to prescribe. It's got 300 milligrams of acetaminophen plus 30 milligrams of codeine, scheduling 1 to 2 pills every 4 to 6 hours. Side effects included the same as what you get for your other opioids, the potential for respiratory issues. It will result in sleepiness, etc. This one does still have a ceiling effect. Unlike hydrocodone and oxycodone, this still does have a ceiling effect. So when you get to a maximum dosing, more doesn't give you any more additional benefit. Hydrocodone, 6 times more potent than codeine. There's all your different products of hydrocodone. It comes in 5, 7.5, and 10. It comes in combination with acetaminophen and ibuprofen. There's oxycodone, 10 to 12 times more potent than codeine. This is the street drug that people want because it gives them the best euphoric effect. It comes in 2.5, 5, 7.5, and 10. The only preparation you get in combo in the US is with acetaminophen. The aspirin and the ibuprofen were discontinued in the US. The last one we'll talk about is tramadol. Tramadol to me is a hit or miss medication. So for some people, it works really well for pain management. Other people, it doesn't really help. But if they've taken tramadol before, I think it's a great medication to give them. It's also one I think is a good choice to start with as well because there's less chance for addiction issues, etc. Typical dose is 1,500 milligrams every 4 to 6 hours. There is also an extended release formulation. And there's also tramadol with acetaminophen. So at that point, you're getting 325 milligrams of acetaminophen plus the 37.5 milligrams of tramadol. So you're getting two mechanisms of pain relief. Be cautious on this one because you want to be concerned that patients are not taking over-the-counter acetaminophen as well, in addition to this one. And that is it. All right. So I'm going to open it up for questions, I think.
That was, I mean, both of you today get the award for being exactly on time.
I'm at 11:40. I did.
Oh, I was looking, I was like, I'll give him 30 more seconds and I'll come on camera, but sometimes people are short, which is okay because I'm here, or they have to see me pop on, and that means hurry. It's time to finish up, but you were right on time. So thank you for another amazing presentation. I know that there are lots of us out here who have learned a lot, and you always do a great job sharing information and making it very interesting.
Thank you.
And the polls help. I think the polls are so wonderful to make us feel like we're in the same room, even though we may not be. It makes us all feel like we can participate even from a distance. So, okay. So I'm going to go through some of the questions. Again, some of these might be from early on. Do you know if there's any behavioral or lifestyle factors that could hint or indicate a predisposition to addiction?
I think people, I mean, I know I have an addictive personality. I know that about myself. I know that I can justify things. So I think that the people who have a predisposition for addiction, I think that, I don't know if it's easy to ask them saying, do you have an addictive personality? But I do think that people have an idea of whether or not this is going to be a problem for them. And so for me, I just know that that's part of my personality, which is why I don't drink, I don't smoke, I don't do drugs, because I know if I did it, I would do it to the best of my ability. And so I think, again, some of those things that we looked at are saying, lower income, smaller communities. If there's any history of taking alcohol or any other drugs, then I would say that that's probably a big of concern for us.
Let me see. There are so many. Let's see. Let me get to the Q&A. If you have more questions, make sure you put them in here too. Any tips on managing patients with orbital postherpetic neuralgia?
Yeah, so I think at that point, I really do think we need to consider doing things like gabapentin because postherpetic neuralgia is one that is a long-term pain for patients. Steroids are also indicated for that. I just have a bigger concern for giving them oral steroids. It's certainly, I think maybe for a short term, a medral dose pack could be really beneficial for those patients to kind of get them over that threshold of pain. But probably gabapentin is probably the best long-term use for them. Remember with patients for who are over the age of 50, highly recommending that they get Shingrix, the vaccine for it. Zostavax, which was the vaccine prior to Shingrix, only prevented postherpetic neuralgia in about 67% of patients. New Shingrix is over 90%. So patients have a 90% reduction in chance of developing postherpetic neuralgia. I had Zoster when I turned 40, and it was in T3, T4, and it was the worst pain I've ever experienced. It was like, felt like someone with a ice pick was just jabbing me all the time. I actually slept on my bathroom floor for about a week because it's the only place I could get comfortable because anything that touched my skin was just excruciating. So you can absolutely see patients wanting that manage that pain. Um, but gabapentin is really probably the best option, or Lyrica, pre-gabapentin. Yeah.
Perfect. And let me see, I have one last question. Do you know how is addiction versus dependence with Adderall? And how is that different when you need it for ADHD?
Yeah. So it's interesting for ADHD that it actually has a different mechanism in kids than it does adults. In kids, it actually calms the brain down. In adults, it actually speeds the brain up. So it is actually a different mechanism in kids than it is actually in adults. And so I would say at that point, it's probably more of a dependence thing versus an addiction thing. I think when you get to adults, it's a much different prospect. I think that potentially because it's a stimulant for adults, then you're potentially getting into more of that addiction type thing. I would say that it's probably less of a concern for long term. I think people can probably stop taking Adderall and not really have a bunch of like jittery side effects and so on. They might feel sluggish, they might feel like slow of thinking and so on. But long term wise, I think it's probably not near the same mechanism. It's not changing dopamine levels like it does, like the opioids do.